Good morning, folks. This is the Central District Board of Health meeting for Friday, March 25th. It is now 8:30 a.m. I will introduce myself as the presiding chair. I'm Betty Ann Nettleton, representing Elmore County, along with Representative Megan Blanksma. And I want to express my appreciation to those of you who are participating online, joining our meeting. Meeting has been called to order. We'll take roll call by county, starting with Ada County. Dr. Young.
Jane Young here.
Raoul Labrador.
Raoul Labrador here.
Thank you. Dr. Cole.
Dr. Cole here.
Boise County Commissioner Sturm.
Commissioner Sturm here.
Thank you, Ryan. Elmore County Representative Blanksma. Valley County Commissioner Hasbrook.
Present.
Okay, thank you, folks. We do have a quorum, and we will proceed with the agenda. Director Duke, do we have any changes to the agenda?
No changes to the agenda today, Madam Chair.
Okay, thank you. Next on our agenda is a presentation and discussion of the Central District Employee Salary Assessment by Robert Grifford, and I'm going to have Russ introduce Mr. Grifford.
Sure. So by way of background, we had talked about, as we were moving away from the state system to establish our own, which we've done, including our working at CDH employee handbook, which you all approved, and then doing a more precise salary assessment for our staff and for our positions rather than what the state has traditionally done, which is a statewide look at more generic job classes. So we hired Robert to do an in-depth analysis, which he's done. He worked really closely with Gary Foote, our HR manager, and Laurel McMahon, our support services administrator. So we've asked him to come today to share the results and answer any questions you have. And this is going to be a lead up to the budget request that I'll make a little bit later on in the agenda. So Robert, the floor is yours. You can provide a little more information about yourself and share the report and the details and answer questions.
Okay, my pleasure.
Would you mind stepping up to the podium for us so we can see you? Thank you so much.
Yeah, Robert Griffard, I'm a compensation strategist. I've been in HR for 30 plus years. Started here out of school at Morrison Knudsen as the newest gopher on the team, and ended up as the VP of HR for MPC Computers in Nampa. Last 15 years, I've been consulting, do every aspect of HR, but my specialization is compensation. And looking at the project for CDH, approached it with the same methodology that I've used over the decades. And the first thing we do is look at the positions, and not look at the position titles, but look at the position descriptions. What are the duties? What are the responsibilities? What are the qualifications? Then we measure that against the market, and we obtain the market data from one of the largest providers of compensation data, a company called PayFactors. And I've used dozens of different providers, and I found PayFactors to be the top of the line, and have been using them over the last 5 years. And I've had clients from coast to coast and internationally, and still found PayFactors to be the survey of choice. I've double checked it with other surveys to ensure that the data is current and accurate. The good thing about PayFactors is the ability to focus in on different sub-industries. And for CDH, we used healthcare providers and services, and we can also use a different scope of companies. So we used a group of companies that are 100 to 200 employees. And then geographically, we use the Boise metro area as the market. So essentially, we've defined that as the quote market for CDH. And then matching the jobs and pulling the data because of the range of data and the volume of data that we can subset the data very easily by percentile. So we pull the 10th percentile, 25th, 50th, 75th, and the 90th percentile. And then based upon the individual positions, then we measure each of those positions individually against the market and then take an average of all of those positions. And the pay structure that we came up with matches the 10th percentile of the market, which sounds like a low end of the market. But in talking with the folks in leadership here, we look at it from a total compensation standpoint. Then the benefits package also weighs into it, and the benefits package here is above average. So we feel confident that if we have pay that's starting at the 10th percentile, that we can attract qualified candidates. And then with pay ranges that go up and match the middle of the market from the midpoint, and ranges that reach up to just shy of the 75th percentile, that we can also hold on to those people with higher qualifications and strong performance over time. And the we look at it also from a standpoint of where people, once we create the structure, then where do the people fit into that structure? And we do it with a range ratio analysis where we compare each individual employee to their pay range and how far do they penetrate into that range. And looking at the entire population, 24% of the population falls below the minimum of the range and 3% is above the range. So 84% of the population is in the range, which in compensation parlance, we call it in the market. And then what does it take to bring those people that are below the range up to the minimum of the range? And the annualized cost of that is 123,000, which represents 2% of the payroll. We were also cognizant of the living wage for the Treasure Valley. Living wage as calculated by MIT University. And that living wage is $14.12. So the only pay levels we have below that are for part-time positions. If someone's working full-time here, making a career here, we do feel it's important that we provide a living wage so that they are self-reliant and self-sufficient. The compensation strategy, every company should have a comp philosophy or a compensation strategy. And we've worked through it here and have a solid comp strategy where we've defined the market, who is our market, where are we with respect to that market, and where ought we to be with respect to that market. And we found that we're a little bit low to that market, so we have some ground to make up there. And that's where we are at this point. Next steps, everything to this point has provided a base for us. And now we move on to the next phase, which is implementation and communication, which each of them are equally important to the development of the comp structure itself. Questions?
Robert, I have a question. Do you have the pay scale in here as well, the CDH now?
Yes. I don't believe it's in the report you have there, but I do have a copy of it here that I can leave or I can provide later, or if you have specific questions on that pay scale.
Oh, here we go. Yeah, I got it.
I believe you're looking at the same chart I have there, which lists pay scale on the left by alpha and so that easy to look up individual positions and then a high-low sort so that we can look at the hierarchy of positions from the highest level position to the lowest level. There's also a list of all employees and what their grade is, what their pay range is, and what their range ratio is, and if they are below market, what would be the bring to minimum cost in dollars and also as a percent of their pay.
So,
Yes, who's speaking, please?
Let's get that code from Melvin.
Okay.
so then the front page, the big fold out page, we're basically short about 11% as an average.
Uh,
10.9.
Well, depending on how you look at it, if you look at it from an annualized cost, 2% would bring people to minimum. But the overall range ratio is 23%, which means that we are not paying the average person higher than the first quartile of the pay ranges. And given the seniority and the skill set of people, we would expect that to be closer to 50%. So you might say we're 27% below where we'd really like to be. It's a big leap to make, and it's probably a multi-year process.
And our payroll now is a little over 6 million. Where did I see that? Is that what you got?
It's more than that, right? Annual. Yeah, I think it'd be easy. It's about 80% of our budget.
Where did I see that?
Robert, you say a multi-year process to get to where we need to be. What is your just recommendation as we use as maybe a guideline for that time frame?
And addressing that in the compensation philosophy, the strategy too, to be able to define where we think it's appropriate to be in the market. But within the compensation philosophy, we put in there all of the considerations in addition to the definition of the market. What type of people do we want? What qualifications do we want? We do not want to pay people with lower qualifications, lower performance, high in the market, but we want the opportunity for highly qualified, high-performing people to be well into the market, to be above the market. So in looking at that, it requires that we do it on an individual by individual basis. But the overriding consideration, of course, is funding. And if we were to say, this is exactly where we want to be, and the cost of that is X dollars, and we know that in this year, we can only get 0.4x dollars, 0.5x dollars. And the remainder, that'll tell us how many years that we're shooting for to come up to parity there. When you couple it with turnover and also the organization, people don't leave an organization strictly for pay unless it's atrocious, but if pay is close to the market. People work for an organization because they like what they do. They like the people they've worked with. They like the culture of the organization. And that's an advantage that you already have. Compensation is a short-term motivator, but a tremendous demotivator. So the intent is to ensure that compensation stays out of the demotivator category so that it's now foremost in the employee's mind and the employees focusing on the work to be done and focusing on their career.
Do these numbers include the benefits package value as well, or are these just raw salary numbers? Okay.
Yeah.
Is there an estimate as to what that benefits package is worth?
There is a non-quantified estimate of that, and quantifying it as good, better, best. It's somewhere very close to best.
And in the counties, Ryan, that's about 30%.
Okay.
Question, Russ, for you, which position is the hardest ones to keep full? Where's your biggest challenge as far as retaining?
So it's varied through the years. We had challenges, we've always had challenges in healthcare.
For like nursing?
MAs, nurses, clinician level staff. We also at times have had challenges with IT, hiring and retaining historically, and that's not just unique to us, but currently it's all across the board. So we have, which could explain a little bit later, but basically our turnover for our full-time positions, these aren't temps and limited service positions, is 20%. It's about double what we used to have. And it ranges from entry-level positions up to management level positions. So it would be really difficult for me to tell you with any certainty it's this position or these two positions job, by job description. It's across the agency and all positions.
Well, the reason I ask that is because we're not gonna be able to come in and fund this all in 1 year. This is gonna take a 5-year kind of a process to get everybody up there. But in the meantime, we need to concentrate on those positions that are really hard to keep full. Now, for example, in the counties, it's dispatch. Dispatch is a huge rotating job for all counties. It's just not a very fun job. So we concentrate on that salary, those kind of salaries first, and get those up to where hopefully that'll retain people, make them stay. That's what I'm saying, is there's a priority of who gets
Right.
that money for the first few years, I think.
Madam Chair.
Yes.
So my plan is, which I'll present to you as far as the budget, is to do cost of living and merit-based. And then, because we just got the report and we know we're going to have to make those adjustments. And as Robert just described, there are certain positions that are I think much higher priority based on they fall below that low end of the market.
Yes, those would be the next on there. And the range ratio is designed to be a metric of that, so that if you take not only individual range ratio, but if you take a department range ratio, dispatchers, if the overall average range ratio for dispatchers is below the average for the rest of the company, then that's a focus. That's where you need to look at. And in addition to that, we're at a point in time well into the Great Resignation. But my personal opinion is that Great Resignation hasn't hit healthcare yet. Healthcare professionals are different than commercial professionals in that they have seen the war, they've seen the battles, and the loyalty is there until the war is won. And as we get closer to winning that war, we're going to reach a point where the healthcare professionals are going to say, okay, I need a break. And, pay may not forestall that break, that there might be other things that have to be done. There might have to be some other HR programs, somebody that's just been working flat out for 2 years. Maybe they need a month off. Maybe they need 2 months off. There's other things there. In HR, you have a full set of arrows in your quiver of which ones to use, and compensation is a good sized one, but it's not the only one.
So Madam Chair,
Yes, go
Robert,
ahead.
question, I know what we're looking at on the county level is there's some people that want to work 3 days in the office and 2 at home. And I think we're gonna see more of our labor shift going to that. The tough part is you gotta build in the IT into that job. There's a cost for IT. For them to do that, but it's working great because we're retaining those employees. A lot of, appraisers
Yeah.
work from home because they can do a lot of that stuff that they don't need to be in the office.
Yeah.
And in our situation in Valley County, we're kind of jammed up for space in our courthouse. We just don't have enough offices for everybody. So it's worked out really well for us, but I think that's going to be kind of the labor model of the future. I do like your comments about some of these nurses, some of these folks that have been in the battle with COVID for the last 2 years, probably are going to want to maybe take a breather and come to work for somebody like us where it's not quite so demanding, the hours are better.
Yeah, one of my sons works in the emergency room in St. Al's, and he has, like all of his colleagues, been under a tremendous amount of pressure through this, and they're starting to feel the relief a little bit. But with that relief comes, what damage have I done to myself? Some of them are actually suffering PTSD, and what do they need in order to be able to get through that? The ideal would be to ensure that they have sufficient incomes to take care of their needs. But now we need to take care of the rest of the person. We need to take care of that whole person, the emotional person, the psychological person.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
So I have 2 questions. Number one, is there a way to actually chart the compensation and the benefits on the same scale? Because I think you said the compensation is low, but the benefits are high. Is there any way to combine them both and to determine whether, as a package, we're high, medium, or low?
I'm not sure I heard all of that.
So you said that the compensation is low and the benefits are high. Can you hear me?
Yes.
So is there a way to chart, to combine them so we can chart whether the combined package of compensation and benefits is high, medium, or low?
We can easily estimate it. Quantifying it is a little more difficult. It's easy to get pay data in the market. It's not as easy to get benefit data in the market. But Gary from HR here has a really good feel for what the benefits packages are. And we can actually sit down and come up with a methodology of assigning relative values to that package. And right now, as I said early on, that we feel that we're pretty close to best, but we're somewhere definitely higher than better. And we could actually put that on a scale to get a little more precise.
Yeah,
In the
I would
end,
like
do I
to know
think we're going to have any more ammunition to make decisions? Possibly, but most likely, we know what we know now.
Okay. Then my second question is, I assume the market includes private, so how do these salaries compare in the public arena? for similar jobs?
Well, the market definition that we used was healthcare organizations and services, which includes clinics, hospitals, any organizations that are involved in healthcare, not focusing on nonprofits. And even though hospitals say they're nonprofits, the market pay rates do look pretty comparable to the commercial market. And also the positions that move back and forth between healthcare, nonprofit, and commercial businesses, like the administrative backroom, HR, we can compare to all HR, IT, we can compare to all IT, finance and accounting, we can compare. And the proposal that we put together is appropriate for those comparisons.
Yeah, but those comparisons are in the private market, correct? I'm just wondering, these are public jobs. So do we have a comparison of similar types of jobs in the public market, not in the private market?
That was not part of the scope to compare to public jobs. So I did not pull that data. But when I have pulled that data in the past, public jobs will run 3 to 5% below the rest of the market.
All right, thank you.
Discussion, questions for Robert?
Madam Chair, this is Al.
Yes,
A
go
quick
ahead.
question, Robert, on page 4 of your draft. You make a statement in here that cost of bringing employees up to the range minimum is 123,000. Is that, am I reading that right? That's for the whole, that's not right, is it?
That's just those people, 28 people below the minimum. That's what it's going to cost to bring them up to the minimum.
Okay, for those that are below the minimum.
Yep.
That's probably the first place we ought to think about starting.
Any further items for Robert?
Thank you for your work. Appreciate it.
Yes, thank you so much. And
Great organization.
thank you. Thank you so much, Robert. It's a pleasure to meet you.
Thank you.
Okay, proceeding onward with our agenda. We have, I believe, an individual that has signed up to speak to the board. And that person will have 3 minutes to present their presentation. So that would be you, ma'am?
Yes.
Okay, go ahead and step up to the podium there. Welcome. Would you introduce yourself, please?
Good morning. My name is Peggy Carrick. I'm a resident in Boise, Idaho. I've come to talk about the mask conversation that you're going to be having. And I have some concerns based as an educator. I'm a retired teacher and a retired teacher educator. I have a BA in elementary education, special education with a master's degree in counselor education with an endorsement in English as a second language. I guess one of the best ways that I can emphasize my point is to talk to you as a ESL teacher or as a reading teacher. I'm going to put on my mask and I'm going to do a lesson for you in a mask, okay? This is maybe to first graders or to kindergartners. And we're learning phonics. Can everybody see? Okay. So I'm going to teach them how to say this word. Bat. Bat. Now I'm going to do the same thing with this mask off. And I want you to tell me what you see as the difference. Bat. My emphasis being that what children are losing in having masks on academically is rather significant. And when you look at the younger children, it is especially significant because of what the phonics that they're learning, the tier 1, tier 2, tier 3 vocabulary that children are learning. They need to have that visual cue. My second example is I moved, after I retired, I moved to Mexico for 4 years, and I became a language learner. I had minimal Spanish whenever I went, and so every stride I made, I was really proud of myself. So one day I decided I was going to really take a risk, and I was going to go out and I was going to try and find a particular location that was like an anchor in my city. And so I went out and as I went downtown, I wanted to find this location. So the phrase would be, ¿Dónde está? So I said, ¿Dónde está la albóndiga? And people looked at me and they said, like, no sé, like, I don't know what you're looking for. Well, I was pronouncing it wrong. So there was and people in Mexico would never correct a senora, my age, because it would be disrespectful. So they would just not saying, and they trying to figure out what I was trying to say it exactly kind of thing. So finally I thought like, oh, they must be tourists. They don't know where this is, because I'm obviously saying it right. So then as I proceeded down, I found an older woman who was the working person. And I said, ¿Dónde está la albóndiga? And she looked at me and she said, in English, can I continue or do you want me to stop? She looked at me and she said, you're asking me where the meatball is. Oh. And, like I'm mortified, but I'm trying to be like a good language learner and kind of hang in there. And what happens in Mexico, which is just phenomenal, is that many times people will model and then you mirror back. And so she said, what you're looking for is la albóndiga. That's very different than albóndiga, okay? So I spent my 4 years in Mexico looking at people's mouths to learn how to say words, because those words were not familiar and my muscles in my mouth were not developed. And so had you taken this and done that, I would have never understood her, even whenever she did the phonics. My last example for you is I took a drawing class at the Park and Recreation in Boise. And I have asthma. And so at the time I took it was in October, I had to be fully masked. So I was underneath we were 6 feet apart, and well, they did a good job and they were vigilant. I was underneath a vent and the vent had air conditioning and I started to cough. And I coughed to the point that I was like hyperventilating into this mask and just like go back and forth and like beside myself. So finally I went like this and I tried to cough and the teacher came over to me and he said, put the mask on. I will lose my job if you do not put the mask on. It needs to be above your nose and under your chin. So here I am, I'm red. I have tears coming down my eyes because I'm coughing so hard and I can't breathe. So I leave the room, but then I come back and I sit back down. And you're just mortified. You're just like, oh God. And he yelled at me in front of all these people. Oh my gosh. And I just want to say to you, what happens for children whenever we're constantly readjusting and put that mask on? And so I just want to ask the question of you, that now that we have the data, and now that we know that basically these masks are not protecting anyone, and these masks are not protecting anyone, and that's what children are going to school in. What are the benefits that children are gaining from the masks, and what are the costs that children are paying for those? And I want you to think of that as mentally, how do kids react to having a mask on, and what kind of how are we conditioning children? Emotionally, like this situation with me, how much time do teachers spend focusing on those kids that can't keep that mask on, who fool around with those masks on? And it's not because they're defiant, but that's what kids do. They touch things, they drool, they move things around, they do things that's what they do. And then academically, what is the cost? And the last point I want to make is that you have made an incredible difference in what you do as this health agency. And so I want you to consider this as you move forward with whatever mask recommendations you make for children. And for teachers, in the end, academically, we want them to succeed. and it makes it very difficult with this on. Thank you.
Thank you. Thank you.
Am I supposed to stand here for questions?
Well, that would, and does anybody have any questions or discussion points? for-
No, gracias por eso. Si quieres albóndigas, los puedo cocinar muy bien. Gracias.
Thank you so much.
Thank you.
Madam Chair, this is Raul.
Yes, Raul.
I just want to thank you for your testimony. That was, I couldn't have said it better myself, and you did make me hungry for some bowl. So I'm definitely gonna have to say, but
You make a difference.
Thank you.
and the thoughts about this is affecting
Raul, you're really breaking up badly. We can't get most of what you're saying.
Your signal is masked.
Yes. your signal was mixed. Okay, proceeding on with our agenda. Under new business, next we need a motion to approve our January 28th, 2022 board meeting minutes. If there are no corrections or additions, Dr. Pope.
Motion to approve.
Okay, we have a motion to approve. Is there a second?
Second.
Okay, we have a motion and a second to approve. I will take roll call by county, starting with Dr. Young.
Jane Young, aye.
Raul Labrador.
yes.
Thank you. Dr. Cole.
Dr. Cole, aye.
Commissioner Sturm.
Commissioner Sturm, aye.
Thank you, Ryan. Elmore County, Megan, are you on yet? No, she's not. Valley County Commissioner Hasbrook.
Aye.
Okay, those minutes have been approved as presented.
Madam Chair,
Yes, Russ.
we have a second person that actually came in to present.
Oh, you do. Didn't know we had more than one person signed up, so.
She
Yeah,
supported her
that's-
friend. I was just watching.
Oh, you were just watching, did you?
She was,
Did you want to speak?
no.
Oh, okay.
Thank you though for the offer.
Okay, thank you. Okay, proceeding on with staffing changes will be addressed by our Director Duke.
Yeah, so just real quick, Jamie Annenson has rejoined Central District Health Department. She's now our division administrator for the Division of Community Environmental Health. So Jamie actually started working for us in April of 2012, and she was our health promotion and health policy program manager that's now occupied by Laura Smith, who you've heard from a couple of different times. Jamie left and went to work for Southwest District Health. She actually promoted into the same position she's doing for us. She was there for a little over 2 years before coming back. She has a BS in athletic training and a Master of Science in Health Policy from Boise State University. So Jamie is joining us virtually. Jamie, I don't know if you want to say anything, share some thoughts with the board, but that would be great if you could.
Thank you, Russ. Good morning, everyone. I'm
Jamie.
pleased to be back at Central District Health and looking forward to working with all of you.
Good to see you.
Thank you.
And the second person I wanted to introduce is also not a stranger to Central District Health, but Bailey Peterson joined CDH in 2019 as a financial specialist senior. So she's been doing a lot of our budget work, but more behind the scenes. And now she's on the stage and in the front of the scene as our finance section manager. So she'll be very directly involved with the budget discussions we're going to have today. She's actually going to present the budget to you, budget to actual and cash balance reports, because Laurel McMahon's on vacation, spring break with her 2 boys. And Bailey will also be very involved in developing the budget that I'll be presenting to you in April for approval. So she's on the agenda for later, but by way of education, Associate Science in Business Administration from CWI. Then you went on to NNU, right?
Yes.
So CWI.
Yes.
Then NNU, got a bachelor's in accounting and business administration. So mostly correct.
Yes, I thought.
No problem. Okay. Well, we're pleased to have her. She has brought great knowledge and the experience she's had already made her a perfect fit for moving into the finance manager role, and she's doing excellent work.
Thank you. Welcome. Okay, we're going to be discussing budget guidance for the 23 budget and the compensation plan that we were just heard from Robert about. So Russ, take the floor.
Yeah, thanks, Madam Chair. So this is the board meeting where I present my ideas and my recommendations to the board for, this isn't approving a budget. This is just looking at a couple of factors that you have direct, I call it, control over. So when you think about our budget is structured, about 40% of our budget comes from sub-grants, primarily through the Department of Health and Welfare, DEQ, Office of Drug Policy, probably forgetting a few. Historically, 20% of our budget came from our counties, 20% state appropriation, and that leaves a balance of about 20%, which comes in through fee revenue. That could be through clinical services and billing and insurance, and then a lot of our regulatory programs like environmental health, where we charge license fees and septic permit fees and things like that. This year, the big change is the state appropriation is being phased out. So the current year we're in, as a result of House Bill 316, which passed in legislative session 2021, the state appropriation for the current fiscal year essentially ended on February 28th. The counties then pick up 4/12 of that budget, of that state appropriation for the balance of this year. Starting on July 1, the counties will be paying 100% of what the state previously paid. Historically, those budget figures were nearly identical for our health district. It may have not been exactly that way for other health districts, but our counties and the state appropriation was about the same. So that occurred. Commissioner Hasbrook, Commissioner Sturm could probably provide some of the details on the politics of that and the negotiations that took place. The legislature was, I think, committed to having the counties pay a larger share for Medicaid expansion, and that money was going to come from either revenue sharing or they were going to fund the public health districts. And as I understand it, I don't know about understanding it, but as the outcome was that House Bill 316 passed and the counties agreed through the Idaho Association of Counties that they would fund the health districts. And the mechanism by which they would do that is, or a mechanism by which they could do that is using the county indigent fund. So all of our counties have been taxing for indigent care for decades, and burden of that program placed on the counties was lessened considerably, not to zero, but lessened considerably because of Medicaid expansion. So the resources, the funds should be there, at least in theory, to make up this difference. So just wanted to give you that background because it's really important. We're going from 20% of our budget funded by the counties to 40% of our budget, and that's rough but close. Of course, we'll be very specific on the dollar amount. So two things I would like to do. Number one, I'm going to talk about salaries because that really drives my recommendation on the county share. So on the salary side, as I mentioned earlier, our turnover rate is double what it's basically on average what it's ever been. So And it's positions all across the board. You heard from Robert, and we do have to work through, as Raul talked about, we do have a better benefit package, but like he said, it's about a 2 to 3.5% difference. This isn't a 27% difference or a 22% difference. So we're clearly well below the mark. We knew that from all the state studies historically anyway. And as we made incremental steps to close that gap, well, the private sector made bigger steps. So it just created a larger spread is what I would call it from where we need to be. So my proposal that we'd like to build into the budget, which Bailey and Laurel and I have talked about already, we know we can do it with the county contribution that I'm going to ask for, is to do a 2% cost of living increase. So everybody in this agency would get a 2% increase, and that would be for fiscal year 23, starting July 1. I'd like to do an early implementation on that because we can afford to do it with the COVID money and the offsets that we've had, and you'll see that in the cash balance report that Bailey provides, and then an additional 1, 2, and 3% based on performance. So we have a 4-tier system today, does not achieves, and then achieve, solid, sustain, and exemplary. So within those categories, an employee who got an exemplary, if this is approved, and ultimately if you approve the budget and the counties approve the budget in May, would be employees who get either a 3, 4, or 5% increase. On top of that, what I'd like to do is looking at the positions that Robert talked about that are below market, below minimum, is to do some additional, add some additional compensation to those particular positions. You know, he had mentioned that was going to be, what, $128,000, $123,000 to do that. So I don't know if we'll be able to do it this year, but that's what I'd like to budget for. And again, back to the turnover. So I also want to share my second part of a 3-part presentation on the salaries is the state of Idaho is doing a 3% cost of living increase and then up to $1.25 merit based. So you can say, well, what does that look like? Well, I'll tell you, for $15 an hour employee, they got a 3% cost of living increase and they got $1.25. That'd be an 11.3% increase. For a $30 an hour employee, 3% COLA plus $1.25 would be a 7.2% increase. And we've lost a lot of staff already to state agencies. We've also lost a lot of staff to the health systems, the nonprofit health systems here in the Treasure Valley. So we're probably even on the low end, but I do want to make up the difference for the employees that are below the minimum. So I think this would be a good opportunity to do that. I would also want to come back. I plan to come back at the October board meeting and present some ideas for retention incentives. And we haven't put a plan together, but to make that effective in December, and it'll, again, depending on where our budget's at, but retention incentives are one-time funding. So that's not an ongoing liability that we carry into the future, but it would also potentially help us slow the very high rate of employees leaving the agency. As Robert noted, and you hear this all the time, mission, culture, all that matters. We don't really have employees saying, I am leaving because I'm getting paid more, but the majority have reported they are getting increases in salary as a result of their move. Does that make sense? They're not moving because of pay, but they are getting paid more when they're heading to their new jobs. So 80% of our budget is personnel, around $8 million. We'll get the specific numbers for you. So looking at how much the county share is, what I'd like to do is ask for a 4% increase from our counties, and we've never done that. We've always asked for a 3% increase, but I will also share during the recession years, we asked for 0. So we've not been irresponsible, in my opinion. But in order to provide a compensation package that's hopefully going to allow us to attract and retain our best employees, I think we will need a 4% increase from the county. So that's my request. Is I shared the compensation plan without giving you the details on the 123,028 employees. I'll share more of that in April, and a 4% increase from our counties. And that's what I would request your support to do that. We designed the budget based on that, or if you have other ideas for the April 15th meeting, and then ultimately present it to the counties on May 20th for final approval.
Thank you, Russ. Our county commissioners like to weigh in on that.
Well, yeah, Madam Chair, I guess my thinking is right now, because of the economy and the growth factor in Idaho's achieving, for example, in Valley County last year, we gained about 72 million in new value, new construction. So you take that times your levy rate, that's how much more tax revenue you get in. What I'm saying is there's going to be years where we don't have that kind of growth. In fact, if you remember in 2006 and 7, everybody lost value big time. Like in Valley County, we lost over 2 billion in value. So when the economy tanks, we're all going to go down together, is what this is going to lead to. Russ, I had a question on, I know somewhere I saw figures that like in, for instance, in Valley County, we had about $40,000 left. I think the other counties had some money still left in their indigent fund to do this. Now, keep in mind that one of the big concerns we have is that with the 316 bill is it did not cover undocumented workers. Counties are still going to pay those indigent costs for undocumented workers. Nobody knows what that is. In some counties, I'm assuming it's going to be high, especially ag-based counties. Believe it or not, resort counties have a lot of undocumented workers as well. So we're kind of waiting to see what that figure is going to come in. That $40,000 is going to have to cover that. Otherwise, it's going to come out of general funds. So there's some things that we're still waiting to see the data on as far as undocumented workers. And then we also pay a great deal towards cremations for a lot of our citizens. I mean, I think in Ada County last year it was about 1.2 million in cremation costs. Valley County, it's probably 20,000 a year. And an average cremation is about $1,700 a person. So there's still costs that we're going to incur. We're still going to levy for that indigent and to fund the public health districts. But I just want to restate that when the economy is great, it's fairly easy to do that. The economy tanks, we're all going to suffer. That's one of the trade-offs from going to county funding. So just keep that in mind. It would be nice maybe if you guys can figure out how much each county has left in that budget. Because I know like ours, I told you, ours around 40,000. I think Ada County was quite a bit more, wasn't it?
Madam Chair?
Yes, go ahead.
Yeah, so what happened is Medicaid expansion was approved by voters. We know that. That's how it worked out. 2018, November 2018, people started signing up. By January 1st of 2019, they had coverage. So 2019, you should have 2019, 2020, and 2021, like the figures that you're talking about. So I did talk to Clerk Miller, which is great to get kind of some intel on this, is counties actually reduced because of the amount of money they had in that fund. They reduced the taxing, the levy.
The levy rate, yeah.
So the levy opportunity didn't go away, but you weren't levying for money that you essentially didn't need. And I don't know what each county did, but I mean, that's up to the individual counties. They do have the ability and the authority to continue, at least as of this year, levy or whatever amount you would need. So to me, it'd be based on the public health district budget now that you're expected.
Oh, exactly. Yeah, that's going to be the base of that levy rate
Right.
for indigent. But the issue is we're still under the 3% cap. We can only raise our budget 3% a year. Now, if we have different levies, we may not be able to raise that indigent levy because we got another levy over here that we have to handle. One of the big things that's happening right now for counties is the state is finally coming in and saying, we're going to take over all your public defense costs. Huge costs. In our case, it's probably close to 400,000 a year.
Right.
Mm-hmm.
That's going to go away. But we can no longer levy for it. So that levy basically goes off. Now we have fewer levy rates that we can get that up to that 3%. You know what I'm saying?
Plus new construction.
New construction is, I guess you might say, the emergency fund for most counties.
Okay.
Not Ada County, I'm sure has, it goes into their regular budget too, because they have so much new construction. But if you don't have any new construction, oh boy, now you're looking at probably everybody staying the same at least for another year until the economy takes off. So, and I'm glad, the counties are glad that we got, I guess you might say, the funding aspect of the health districts. I think there's gonna be some counties that are gonna say, we really like this, and other counties that say, no, we don't like health districts, and there's gonna be some battles with counties on some of this stuff. I like the idea that, to me, it's kind of like the same issues we deal with our labor force in county government, we're gonna have the same issues with the health district. So we're all kind of gonna be on the same level as far as treatment and you know, the sad part is your 2% COLA or your 3% COLA is not gonna keep up with inflation. And we're all gonna be going behind another 2%. That's gonna be the challenge in the near future. And we may be able to make some of that up with benefits packages. Maybe we want to take on a bigger share of the families of our employees, the cost of that premium. That's one way that we've done it through the county. We pay 50% of the family's premium and 100% of the employee. Now, it used to be we paid 60%, but we had some employees that had 4 or 5 kids, and we had other employees that were single. So it wasn't really a fair way to do that. So we just came back and said, we're going to do a policy that will pay half your premium cost of your family, any family members, but only up to 50%. You're going to have to pay the rest. But Gem Plan has been phenomenal. It's probably the best insurance in Idaho that I know of, especially for counties. It's a $500 deductible and no copay. So that's a big benefit to employees to know that my medical costs are going to cost me $500 a year per person in your household. And then everything else is going to be, that's a great incentive. Especially if you have people that have family members that have long-term health issues. That's a big employee incentive as well. So there's other ways besides salary we can look at this. Pay time off, increase those days. You know, there's different things you can do. Sure. I hope it, in the long run, I think it's going to be challenging. But I think if it's going to be right down to the nickel every year on a lot of this stuff, but we can do it.
Commissioner Sturm, would you like to weigh in from Boise County?
Yeah, so a lot of what Elt said is kind of the same boat that we're in. You know, I don't know exactly how much Boise County has in reserve as far as the indigent fund goes. I'd have to talk to our indigent person for that and find out that exact number. But you know, we're in the same boat. We're struggling. We're doing our own step and grade analysis this year for Boise County and looking at trying to continually increase our own employees' wages. And so now that we're, you know, under the state going to have to pay for the 100% of our health district, that's gonna impact us quite a bit, and I don't know what that's gonna look like. And so there's some information out there that, you know, that I would have to get from my people, from my clerk's office, and see what that looks like on our end to kind of feel more comfortable, you know, making a definitive decision. That's it. That's all I had.
Thank you, Ryan.
Madam Chair, can I just add one more thing? I know you guys are tired of hearing me, but the way 316 came about was the state came to the counties and said, we're going to reduce your share of sales tax revenue in order to cover the Medicaid expansion. And we sat down and went through those numbers and we said, wait a minute, that's a bigger hit than if we used our indigent funds and you guys. So we didn't want to give up that sales tax revenue. In fact, that sales tax formula has increased. Because that's where the 1.2 billion came from in the state this year, was sales tax revenue because of online sales now are paying sales tax to Idaho. And so we knew that was coming, and so we didn't want to lose that percentage of sales tax revenue. So we came back with the idea of using indigent funds to do it that way. That's where all this started. This is so everybody kind of understands that.
Thoughts? It's a slippery slope right now.
Yeah, Madam Chair, I kind of agree with Elt. As we go into an inflationary period right now, that can slow an economy. And so I think he brings up a valid point of the steadiness of cash flows are never predictable, obviously. And, we can hope because we have such a great state that we continue to grow, but some of the inflationary pressures, I think, may change that. At the same time, I agree with Russ that we need to adapt to those inflationary changes to keep good people. So it's a paradox.
It's,
Madam Chair,
yes, Russ.
one other thing I would add, just thinking about it, if you agree to the 4% county contribution increase, and if the county commissioners, the board of commissioners approve that in May, you can always make adjustments next year and a year after as things change. The 4% would be permanent unless we ask for a reduction in future contributions. But when the recession hit that you described, Al, we did not ask for increases from our counties for 2 years in a row, and then we started stepping that back up again to get back to 3%. So this isn't committing to 4% for the next each year for the next 5 years. It's trying to address the problem that we have today with the resources that generally there's a lot of building, a lot of growth. We also know the impact to our staff has been significant for the first time ever. And I talk frequently with Public Health District 3, Nikki Zog, the director there. She worked here, as you all remember. We are having people that were from out of state that apply for jobs here, and we set up interviews, and they say either then or maybe even after the interview at the job offer time, can't afford to live there. Sorry, I wasted your time, didn't realize it, but I can't afford to live there. So we were always operating under the premise that we're cost of living in Boise, Idaho, even in Boise, is really inexpensive compared to the most bigger metropolitan areas in the country. That has changed dramatically. So we're in a very unique position where our wages are very much lagging. People, look at the rent prices. We're not talking about buying the average home price in Ada County with new construction at $565,000. We're talking about rent that's mirroring that. It's unaffordable. And then if you want people to drive, which we have an employee, she recently left partly for this reason. She was driving from Ontario, Oregon at $4.53 a gallon. That's a pretty tough pill to swallow. She quit swallowing it. She works for District 3 in Payette now,
Madam Chair, I guess too, the other thing to think about is, okay, when you're selling this increase to the counties, I would bring that past history with you. This is what we've done the last 5 years.
right.
We never took a increase in those years that it was tough.
Yeah.
My question to you is, what are you gonna do if the counties say no?
I'm sure, if the counties ultimately don't approve it right on May 20th, we have to have a balanced budget for July 1. That's the start of our state fiscal year. We'll have to adjust our budget, and the primary mechanism by which we would do that, with 80% of our budget being personnel, is it'll come out of the used to call it change in employee compensation, but the salary structure we're proposing. And we can look at other areas too, operating costs and what have you. But again, the bulk of our budget is personnel. We're a service industry.
Yeah, I think that's gonna be challenging. When we went through it back in the crash, we were down about 6% on our salaries. And so we had a juvenile detention facility in McCall that we had maybe 3 or 4 kids a year our own kids, Valley County kids, and we were taking other counties' kids in, trying to supplement that income, but it was about a $380,000 department. We closed that down and ship our kids down here, and we saved over $300,000 by doing it that way. We since leased the facility out to McCall City Police, and we make $2,800 a month off that facility. We saved $300,000 a year. We took that money and gave everybody a 6% raise. So what I'm saying is we need to have, you guys need to come up with some fallback plans. How can we, and like we're short 123,000 right now. Is that one position in this facility that we do away with and use those funds to give everybody else that? Those are the kind of decisions that we're going to end up making down the road if the economy crashes.
Madam Chair. Yeah, and it wouldn't be the first time we've gone through that. We've referred to the housing recession. So over a 3-year period, starting in probably budget year 2009, the state appropriation was reduced by $750,000. So we had about a $1.4 million adult immunization program at the time, travel vaccines. Our staff were recognized throughout the valley as the experts. They kept up on, because it wasn't just giving immunizations, but talking about security and waterborne illness and mosquito-borne, all the things that happen when people travel around the globe. So that went away, and so did our senior nutrition program. So that was, all businesses would have to go through that. I mean, I think being too cautious and continuing to lose employees at a 20% turnover rate, or, it's just trying to adjust that dial in my mind of where do we want to get? We don't want to get ourselves too extended, because I think there's a lot of suspicion that we've been on a pretty good ride economically, and that merry-go-round may stop pretty soon, but it hasn't. And we don't know. And I think my preference is we make adjustments when that day comes and we have the ability to do it. And we've done it before.
Well, and I think it's so important you let the counties know this isn't a permanent thing.
Right.
Yeah, so.
Well, and I would encourage Bailey and all your financial staff to come up with a plan B and a plan C.
We will.
The other issue that I'm going to work on, hopefully through the executive council this year, is food fees. And if we can take those out of the state code where we can set our own food inspection fees, kind of like we do our septic permit fees, because those are not even 50% of what our actual cost is. So we can look at the cost side of things, our permits and our fees and what we're charging. I have been getting a lot of kickback on the septic permit fee. I think it's around $850 now.
There's all the different.
And boy, oh boy, people kick and moan about that one all the time, but I explained to them that it's basically done annually, that it's the number of permits divided by the cost to do the program. That's what the permit fee is. It's the simplest way to do it. So if you don't have many permits, it's going to be a little bit more money. If you have a whole bunch of permits, you can spread that cost out. They'll be cheaper. But I think, not only trying to raise more funds, but also to do it through our permits and our fee schedule can help too.
Sure.
Yeah, and we're going to talk about that in executive next month or May or whatever it is.
Madam Chair.
Yes, Raul, go ahead.
Yes, just a quick question for Russ. Do you have any idea what the other districts are doing and whether they're experiencing the same kind of loss of employees, and whether they have plans to increase their wages as well? Just any thoughts on that?
Madam Chair.
Yes, go ahead.
Yeah, the district directors talk about weekly, and we did share ideas around this. So each district, the conversation often focuses on the county contribution and staff salaries when we talk about it, because it's not that you don't have control. You could say we're not going to accept the immunization sub-grant or the communicable disease sub-grant. You can do that. It's generally not something that comes up during these discussions. The part that you really have very direct influence over is county contribution and staff salaries. So to your question, so kind of all over the board. Public Health District 2 in Lewiston is looking to give their staff a 10% salary increase. A lot of the districts will be similar to ours. We, as I noted, talk frequently with Public Health District 3 because we're in the exact same market now. That's really Canyon County's their hub, Ada County's our hub, and then we have our rural counties. So they're looking at a salary plan the same as ours and a request from their counties probably the same as ours. So I wouldn't say we're the absolute low end. I think Public Health District 6 out of Pocatello, they're concerned about the county contribution, and then they have to adjust their budgets accordingly because of the heavy weight that the personnel side of the budget. So high end is Public Health District 2 from what they shared. Probably we're pretty consistent with average, and District 6 out of Pocatello be on the low end. But you never know till they work through their budgets.
And one of them just lost her district director.
Jerry.
Jerry
Yeah, Jerry
Rackwell,
Rackwell.
Public Health District 7, she's going to the private sector.
And Madam Chair, follow up to actually just a thought.
Yes,
The,
go ahead.
you know, as you know, the Ada County, I think, gives 90% of the county budget for Central District Health. And I don't know that they can guarantee a 4% increase. So I think that's something you need to take into consideration when you're asking the different counties to increase their budget. 90% of it is going to come from Ada County. And I'm not sure that they're going to be in a position to increase their budget by 4%.
Further thoughts?
Well, it wouldn't be necessarily increasing their entire budget by 4%. It would be increasing the levy rate for indigent by 4%, correct? Because that's where those funds come from, is that levy.
Madam Chair,
Yes, go ahead.
if the counties had continued to tax at the same rate they were taxing at for county indigent when Medicaid expansion went into effect, but they didn't because they didn't need the money. But if they had continued taxing at the same exact rate, I think Ada County would have ended up with $4.5 million surplus.
Right.
So I can't tell you why, I do know why they lowered the levy rate because they didn't, the demand wasn't there. Like you talked about with cremations and undocumented, but my understanding is, you can look at the numbers, the state catastrophic fund and the county indigent fund dropped dramatically when Medicaid expansion went into effect. We have 3 calendar years worth of experience. So it's not like we're treading into new territory today as far as.
And I think that would be really nice to know what that budget surplus is in each of our counties right now. I think in Valley County, it's around 42 or 48,000. So what I'm saying is I don't think this is going to hit too hard for another couple of years. And then when we get that levy rate where everything comes up to about 0, then it's where it might get challenging.
Right.
Yeah, Madam Chair, this is Raul again.
Yes, go ahead, Raul.
Just let's remember that the advocates of Medicaid expansion said that this was going to cost the citizens of Idaho less. And what you're saying is that we should actually increase the levy rate because it's really not going to cost the citizens of Idaho less. So we just need to make sure that, when you're asking 90% of the budget to come from Ada County, I'm not sure that Ada County is going to be willing to increase there. And I can't speak for the commissioners, so obviously you're going to have to talk to them. But it's just a thought that it just occurs to me that 90% of your increase is going to come from Ada County, and I'm not sure that they're going to be in that position to increase the budget. But thank you very much.
Jane, yeah, has it changed where the number of counties that are agreeing make the choice? Like if 3 other counties are deciding it, then Because that was the major contention
Madam Chair.
previously.
Yes, go ahead.
Yeah, Dr. Young, in Idaho code, this is sort of the nuances of it. It's majority vote. So if Boise, Elmore, and Valley say yes, and Ada County says no, Ada County pays. But for the new funding, the making up the state share, which is, there's a floor, no less than fiscal year 21 state appropriation counties have to make up. If they agree on an alternative formula for that portion, they can.
It just went right over my head.
Okay, so I'm sorry. So to your question and your understanding of it, you're exactly right. For the money that the counties have always been expected to contribute, it's simple majority. And in our district, it'd be 3 or 4 counties. If they vote to support the budget that you all approve in April, and a 4th county does not, that budget stands. And the 4th county is responsible for whatever that financial obligation is for the distribution formula based on population and tax assessed values. The new money that they're already paying from March through June, and will be that additional share, which will essentially double the county's contribution. If the counties agreed to a different distribution structure, like instead of using tax assessed value and population, Ada County says, well, we're 90% of the budget, the county share, so we want 90% of the vote, which would mean they would get to decide, right? I don't think our rural counties are going to agree to any changes in the formula, because that would put more burden, could potentially put more burden onto them.
That would have to go through legislature to change that formula.
That's what I thought, yeah.
And the rural counties used to say, no, wait a minute. That's not going to be very fair to us.
Well, and we have had that situation
Yeah.
where
Yeah.
there was specifically Ada County didn't.
That's right. That's correct.
Out of 3 counties.
And that was one of the really strong points that we wanted to get across in 316 is we wanted a base budget for the health districts. That 21 budget is the base. The counties can't send less than whatever they were sending at that time to secure the stability of the health districts. That was very important to me.
Good job.
Okay, does that make sense? But
Yeah.
between that base budget and whatever budget they come in on, then's when we'll have an influence on that. So, yeah,
Thank you.
we may have to, push comes to shove and things turn sour fast. We're at least gonna have that base budget. So then all we gotta do is figure out what programs we can eliminate and still stay under that base
Yeah.
budget.
Awesome.
So there's a safety net built into it. However, Ada County could go to the legislature and get enough votes to change all that. Any county could, it's just a process, but hopefully that doesn't happen.
Right.
I look at it in Valley County, I think ours is 148,000 or something a year. And we have a facility up there, we have 3 or 4 employees. I mean, we get far more bang out of 148,000. And so does Ada County. They got all these people working and, there's a benefit to that you got to count, so.
Well, and some of our rural counties are going to be facing unprecedented growth, mine in particular, very soon, very soon. So that's going to be a challenge for us.
That was a lot of forethought to put the base in there.
Well, the only thing that I missed on was the undocumented workers. And we actually talked about it in some of the meetings with who was the senator from? Can't remember his name though. How are we gonna do undocumented? Well, we'll worry about that later. It's kind of the way that conversation.
It's here.
And it's like, well, we're gonna still have indigent bills coming in the county. And these bills can be $150,000, $200,000 bills.
We had one person undocumented in our county that's a $450,000 bill. One person.
And it's an alcoholic that destroyed his liver. And you just go, oh. get it to yourself basically, but that's the way the law's set up.
Madam Chair.
Yes.
So what I would like today is just basically the authorization direction from the board to build our budget around the salary structure and the 4% increase from the counties. And if you have other ideas, then let me know and we'll build the budget accordingly. And that's what I'll be presenting to you on April 15th.
Madam Chair, you might want to think about maybe Bailey could do this for you, a 3%, 4%, and 5%. We got to look at this on the positive side too, that, hey, we got, Ada County's got a couple of $1 million sitting in indigent. Maybe they would be willing to do a 5% or 6%, which will get us ahead of the salary discrepancy that we're dealing
Right.
with now. So maybe look at a 3 or 4 and a 5. Just a suggestion.
Whatever the board's preferences, we'll do it.
I'll make that motion.
Okay. Motion's been made. Is there a second?
Second.
Motion has been made and seconded. Ryan and Raul, could you hear that motion?
Yes.
Okay. We'll call for a vote by county now if there are no further discussion, starting with Ada County. Jane,
Jane Young, aye.
Raul Labrador,
Aye.
Dr. Cole,
Aye.
Boise County Commissioner Stern.
Aye.
Thank you. Elmore County Representative Blanksma, she is not on. Valley County Commissioner Hasbrook.
Aye.
Okay, that motion passes. Bailey, have you signed it?
Piece of
Okay,
cake.
piece of cake, well, yeah. Okay, now we want additional update from the Executive Council by our trustee, Commissioner Hasbrook.
It's time to get we don't have trustees anymore, do we?
That's right. Yeah, that's right.
The trustee part has gone away. Our big discussion has been, we talked earlier this fall about maybe tackling food fees this winter. We decided, it's election year and nobody's gonna want to touch that. So we're gonna wait till next year, I think, to start, and I'm hoping maybe Megan can help us with some of that. We're talking about, IAB is in June, and I think it's gonna be an online meeting. And some of the discussion there is whether or not we want to have a national representative to NALBO. And correct me if I'm wrong, but I believe last year Megan went to NALBO.
Madam Chair,
Was it?
if
Was that the year before?
NALBO was virtual last year,
Oh, that's right.
what Donna had shared with me, because she was communicating with Representative Blanksma. So she was signed up, but I do believe she has some difficulties getting access. And then I reached out to her to find out if she did attend, because she would be expected to give an update at our hosted meeting this year, and I didn't hear back from her, so I'm not sure if she was able to make the meeting or not.
Well, one of the questions the executive council has, and I need really a decision from this board today if possible, is do we want to stay a member of NALBO? And I don't know how much those annual dues are. Do you remember? Anybody remember?
100 or 450.
$450 a year?
It's either 400 or 450.
And you take that times 7 district, it must be around $3,000 a year for the whole state. I don't know how you guys feel about it. And I need to know how this board feels about it if we continue with that NALBO relationship.
So, kind of-
National.
Okay, yeah, and I'm naive in this area. What is the benefit of being a part of them versus not? I mean, I believe in, think in the big picture, but act locally. But if we already are working as a team to act locally.
Well, there's a state, of course, and then each state belongs to the National
Sure.
Association of Local Boards of Health. I can't answer that question, Ryan. I don't know. I've never been to one. I don't know if it's worth our $3,000 a year or not.
I have been to several, and the educational opportunities to move forward with your local districts, I thought have been amazing. I really did.
Okay.
So on the connections that they made for bringing programs from around them.
Exactly.
To here.
Yeah, you make a lot of valuable, there's a lot of collaboration.
I think the last one 2 years ago was in New Orleans.
It's It pretty well dissolved there for
Yeah.
several years. It did. We didn't exist really.
I don't know. I don't know how the board feels. I can't answer what, if it's worth it or not, but I just need to know how you guys feel. We could stay neutral right now until we see what the rest of the districts are gonna do and then make our decision then.
So, Madam Chair.
Yes.
So there's two things going on. You got the CDH want to continue to be a member of NALBO, which you can decide. It's not dependent upon what other health districts do. So today, my understanding is only 3 of the public health districts are members of NALBO. Second component of that.
Oh, that's good.
Yeah, it's 3, again, could be 4 of 7 or 2 of 7. I know we are members, but that's what the last report was. 3 of the 7 health districts are members of NALVO. Then there's a position that you and the 6 other boards decide on, and that is what they call the SALVO, the State Association of Local Boards of Health. So that's just an affiliate group under the national structure that Steve Scanlon, one of our board members, board chair, was very active in. And they would meet several times a year, kind of as a subgroup of the National Association. The National Association works with Congress on policy. They organize the annual conference, and in these state meetings, we're discussing what was going on at the state level throughout the year. They ran into financial trouble. I think that's when Steve was maybe past chair.
Yeah, past year.
Kind of dissolved, reorganized, started having the annual meetings again. Along comes COVID.
Mhm.
Moved to virtual with low participation as I understand it, but I think obviously we're heading in a very different direction right now. So the SALBO position was Dr. Barbara Nelson. She's OBGYN from Idaho Falls. She was elected by the Idaho Association of Local Boards of Health, June 9 meeting, to represent this state. The benefits she got is out of the association budget, which you all will have the opportunity to approve in June, paid for the travel and paid for the registration and per diem. It's not a ton of money, but the 7 health districts paid for that. Representative Blanksma was the vice Salvo representative. She was the backup person. So Dr. Nelson quit. I don't even think she's on District 7's board anymore, to my knowledge. So Representative Blanksma stepped in. And
And then they went to virtual and then she couldn't.
Well, last year was the first year that Representative Blanksville would have been representing the state, would have done that virtually. Don't know if it happened or not. So last year at the Idaho Association of Local Boards of Health, there was a discussion about, do we even want to continue to have a SALBO representative? So that's something, and you can give direction to Commissioner Hasbrook today because he's meeting, Donna, you know when the meeting is.
Well,
May
Yeah,
12th.
thank you, Don.
They're going to talk, and then they're going to make a recommendation to the full body at the June 9th meeting, whether we want to continue to have a SALBO representative. And then you'd vote on them if you decided to do that.
Salvo works a lot hand in hand with the tribal entities across the nation too.
so what did they accomplish nationally? When they approached Congress?
I'm assuming, I'm sorry, Madam Chair, I'm assuming that they have a lobbyist group that they probably fund. Kind of like we do with IAC
All right.
on a national level that watches bills coming out that would affect public health. I don't know, to tell you the truth. I know it's 3,000 a year, and then if we do send someone to an actual conference, then we split those costs 7 ways too, don't we?
Only for the SALBO representative.
Right.
So the 3,000 would be if all the health districts participated in NALBO. That doesn't come out of that conference office. That comes out of our budget, $450.
I looked it up.
$400 comes out of our budget. Each district makes that decision. The only cost that we would be paying for is for that one elected representative, elected not as in state representative, it just so happens she is, elected by the IAB, the Idaho Association of Local Boards of Health, which we're members of. We would pay for that person's registration, travel, and per diem.
Do the other districts that aren't members, do they pay for towards that as well?
Yes.
So that's like an unfunded tax.
It will be decided by the body, and that's what's coming before you all on this May 12th meeting as an executive council member, and then you'll make a recommendation to IAB whether we want to continue with Salvo, not whether each health district wants to be members of NALBO. You get to decide that for CDH. The meeting was in San Antonio one year, remember? It coincided with NACCHO,
What's NACCHO?
National Association of County and City Health Officials.
Huh?
That's me.
That's for us.
That's for us.
Well, actually, of the two organizations that I think the most benefit to us would be
Wait, San
if we
Antonio.
remain a member of residents. So,
So do you want to make that a motion?
I would make that a motion, yes, that we continue our NALBO membership.
I'll second it.
Okay, motion's been made and seconded to continue NALBO membership. And I'll take a vote by counties if there is no further discussion, starting with meeting.
Madam Chair, I do have a question.
Yes,
I guess
Ron.
I guess I didn't hear what the benefits, there were questions about NALVO, and what did you think was the benefit of being a member? Because I didn't hear any that
The
sounded.
collaboration with the rest of the state's public health districts. And as far as moving forward with issues, education, that was tremendous.
Okay.
So, any further discussion?
Yes, Madam Chair, I'm just wondering if, I don't know how to attack this, but maybe we already have a lobbyist. I mean, IACs are lobbyists at the state level. Would I don't know if they would necessarily have anything to do with national level lobbying, but maybe we're already paying for this.
Madam Chair,
Go ahead.
I mean, there's the National Association of Counties, right, that make
And
out,
we're all members of that. Idaho is every county.
but I would say I've never attended those meetings, never looked at their agendas. My guess is public health is probably not on the highest priority for that.
But what I'm thinking is, now that the counties are gonna fund health districts, maybe that's gonna be a priority.
But it would have to be a priority for all states, right? If you're going to shift the policy in the direction for
Good
NACO.
point. That's a good point.
Okay, any further discussion?
Madam Chair,
Yes.
I guess you guys have to vote, but I was just going to say we have to talk about Salvo too, because that's the question that you have to decide on May 12th.
Well, and I thought the Salvo elected person was the one that went to NALBO.
Yeah, but you all can go to NALBO.
Why?
Madam Chair.
Yes.
Well, to Chair Nettleton's point, I mean, I think about, I would, and Raul, you asked a question, I can talk about a very specific example where State Representative Blanksma went to NALBO and learned about syringe exchange programs that other states were doing with the idea of trying to reduce the volume of syringes that are being used for illegal injection drug use, to get them off the street, and also to provide a mechanism for people who are injection drug users to seek help at the syringe exchange point. So she actually learned that at NALBO and then came back, proposed legislation, which was passed. So now we have a syringe exchange program in the state of Idaho. If she were here, she may say, I already thought about that idea before I went to NALBO. I don't really know, but I do know she went to NALBO. She asked me questions about it. She came back, she drafted legislation and it passed. That's just one very concrete example of the benefit of NALBO.
No, I was there at that conference with Megan and worked through those details on that. It's basically an addiction treatment program. And then I believe it was Dr. Fred Woods, worked with Megan to get it through the legislature here. So there's a lot of good education. Okay, we do have a motion On the table that has been seconded, I will call for a vote by county now. Jane,
Jane Young, aye.
Raoul Labrador,
No.
Dr. Cole,
No.
okay, Commissioner Stern. Ryan, are you there? Elmore County. Maybe
Yes,
you're-
I'm here. I'm sorry.
Are you a yes or a no on remaining a now full member?
I kind of would like to talk to Megan and see what what she got from it, since she's the one that went to the conference. But for face value, no.
Okay. Valley County Commissioner Asper.
I'll say yes.
Okay, so we have. And. 3 to 3. And I can vote so I would vote to remain. That's a tie. So the motion goes down.
Automatic, a tie is an automatic no.
Right, and a tie is an automatic no. Okay. All right. Bailey, you want to give us your financial report?
Yes, Chair. Thank you guys for having me today. Come up here so you can hear me a bit better. All right. As you can see on the screen, it is our budget to actual report. This report is through the end of February, which is about 66.67% through the year. Excuse me. Trends continue to be similar to what we've seen throughout the year, with revenues right on track with where they should be at 72%, and expenditures are a little bit below at 60% of budget. Our total fee revenue is high at 73% of budget. Other revenue for support services is auction revenue for some auto fleet vehicles that were sold at auction, and we don't anticipate any more vehicles going to auction this year, so that should remain at 136% of budget. For community environmental health, contracts and fee revenue percentages are both slightly above where we had planned at this point in the year. Other revenue is on target, and that is due to our Western Idaho Community Health Collaborative funding, the Millennium Fund, and the Citizen Review Panel funds. Our family and clinic services contract revenue is higher than we predicted at this point in the year at 79%. Fees are below where we predicted, but that has continued to be a trend that we've been seeing in FCS. Other revenue is high, and that includes our home visitation funding that we get that lump sum at the beginning of the year. Expenditures, as I mentioned earlier, it's a little bit behind schedule at 60% of budget. Personnel remains under budget a little bit more significantly. And again, as we've discussed, this is due to position vacancies and some salary savings due to retirements in the last year. Operating costs are a little bit above budget, but it is within reason from what we would expect for the year. Capital outlays are high, and this is due to the purchase of 3 vehicles, a few facility equipment upgrades, and the completion of the Mountain Home improvement project that you guys have been discussing over the last few board meetings. Then if we can advance to the salary or the revenue and expenditure report, page 2. As you can see, for community environmental health, these continue to trend upwards as they have over the last few years. FCS, we've had some good increases in central care, in the child dental clinic, and then also in home visitation, which has been nice to see. Immunization and reproductive health has decreased compared to prior years. And then that other revenue includes COVID immunization revenue that is, it's the billing of the insurance. billing individuals, but only the insurance for the piece that we can bill for the COVID immunizations. Under contracts, you can see that community environmental health is lower than they were last year, but still higher than in fiscal year 20, and that is again due to the COVID funding that's continued into this year. Under FCS, there's a positive trend for contracts as well. And that a big part of that is due to our immunization program expanding for the COVID immunizations. Looking at the expenditures, as we mentioned on page 1, personnel is under where we expected it to be. Operating capital are both over, but within an expected range. All right, if we can advance to the cash balance statement, please. Looking at the reserve fund designation, you can see we have spent roughly $38,000 for the Office 365 project. Facilities maintenance and service projects and modernizations are continuing to have activity against it. We have filled that grant writer position that was vacant for a little while, and so we should expect to see more expenditures coming up on that. We also filled that AA position in February, so those numbers should be increasing in the coming months. The marketing campaign is nearing completion, and the initial plan should be finalized soon. So we'll likely see some activity on that line in the next few months. And the cash balance less the reserve funds leaves a balance of roughly $3 million in the undesignated cash balance. This is an increase, and this is due to getting the last segment of the state appropriation in January and the Ada County contribution in February this year. I'll stand for any questions.
Madam Chair,
Yes, go ahead, Dale.
Bailey, you said something about the AA funds. Which ones are those?
It is the Health Policy and Promotion Admin Assistant. It's half the FTE. It's the second.
Oh, there we go. There we go. And that one's filled.
Yeah, it is filled.
And I'm assuming your grant writer, you got her in at the 75,000.
I know the hourly rate. I don't have the annual amount. We won't reach that 75,000 for this year just due to the timing of when they were hired. So it will likely be a little bit less than that 75,000, but we did offer them a competitive rate.
And I'm assuming with some of the empty positions you got, you're gonna have some cash carry forward.
Yes, I would.
Do you have any idea how much that is?
At this point in the year, I don't.
Madam Chair,
Yes.
can that cash carry forward go to making up the gaps in terms of budget on the underpaid? You know, to your question, since, you know, we've underused it in certain areas, to your point of cash shifting, just to make sure we're running a balanced budget. If there's a surplus, then it would, just in my mind, make sense to do some of those shifts while we have the funds now.
Madam Chair.
Go ahead, Russ.
Yeah, I hear what you're saying. So the difficulty in making, it's basically that ongoing versus one-time funding. So we have one-time funding if you have position vacancies, which we've had plenty, right? And you have periods of time that lapse between leave and new hires tend to be brought in at a little lower wages than somebody who has experience. So I'm going to be putting a lot of thought into that because we don't want to carry too large of a cash balance. Clearly, it's really ideal for things like one-time retention incentives, things that I really want to figure out a way, work with Bailey and Laurel and Gary and probably talk to Robert some more about what that looks like. So they're truly retention incentives because if you just hand out bonuses, people get bonus and then they're gone. So I have some ideas about it and I'll bring that back to the board. But I agree with what you're thinking. It's just how do we then continue to fund that ongoing, right? We could certainly do it now, but then that leaves us potentially short in the future.
Yeah, and I think, that's a good answer. It's good for 1 year, but the next year you gotta budget that on top of what you normally budget for personnel.
Yeah.
So you get yourself in trouble pretty quick doing that. But I like the idea of using it for capital improvement, other projects.
Yeah.
Yeah. So, oh, I'm sorry,
Go ahead.
Bailey, our total budget's 8.6 million, right? Our total budget's about 8.6.
No, this last year it was not. It is, the anticipated budget is 3.8 million. We're about 8.3 million into it in expenditures. If you look on the budget to actual report at the bottom. And with that reserve funding, we technically have the authority for 15 million to spend if we were to spend any, all of that reserve designation that was approved this year.
So it's almost 14 million.
14 million.
So the 8 million is their salary number. And then we have benefits, operating, trustee benefits, all of that that go into it.
I guess what I'm trying to get at is when you come out to the commissioners and next month or whatever with your budget, it's important to show that you don't have $2 million in cash reserve. You understand what I'm saying? That's what I look at. It's like, and that's what the legislature looks at when they hit the counties and like, why do you have all this money over here in cash reserve? What is that for? So make sure you designate that.
Yeah, Madam Chair,
Go
so
ahead.
we have, you all, this board said, build your operating reserve to 3 months. So that's what we've been working on. It was pretty difficult to get there. But because of the COVID funding, we had a lot of our staff, and I would use myself as an example, who had the opportunity to code my time. So my income during the year and a half or so, 2 years, has been coded to COVID. So rather than that coming out of grant funds and what we call district funds, it was charged to the federal dollars. So it's great in a way that we were able to build up our operating reserve from 1 month to more than 3 months in less than a 2-year period of time. It's not ideal for the reasons you mentioned, the perception that you're sitting on a mountain of cash. In a way, we are, but we also, when I say we are, we're just a bit above the target that you all set. So that 3 months operating reserve is based on the idea, number one, it came from the Legislative Services Office. They say, you know, to be sound business practices is to have enough money so that if your funding stream stopped, you would be able to, basically, you would have to phase out in 3 months or figure out a plan, but it's not going to be day one, you're out of money or have 1 month reserve. So that's the whole idea of that operating reserve. And I assume the counties have reserve funds.
Well, we end up with about, in Valley County, about 2 million in cash carry every year. Because people quit 3/4 of the way or halfway through the year and you don't get that position filled, but and we build that right back into the budget and then try and reduce the levy rate. So, but I like the idea that you've got your capital reserve up. It's actually almost 1 million more than what we need for 3 months.
That's right.
And that's a nice feeling. However, when you come out to the counties and ask for more money or 4%, they're gonna look at that and say, I don't know.
Could we explain how much of it was billed to the COVID funds so that they see that that's gotten into it?
Yeah, Madam Chair.
Yes, go ahead.
Yeah, we definitely could, and there will. The other issue was we talked about this before, it's good that Bailey's here to ask questions to me, is the indirect rate actually dropped because of, again, there's lots of other staff like me who charge to the indirect rate. Because we charged to COVID, the indirect rate dropped. So when we were talking about that money,
Oh, I see. Okay.
you guys decided to move that into operating reserve, but we knew the indirect rate. We built this year's budget based on that. I would call it it's not artificial, it's real. It happened. It caused that indirect rate to drop dramatically. That indirect rate's going to go back up because I now code my time through other funding streams. So it's in operating reserve, but we're going to have to pay it at some point. But the pandemic didn't end. Staff didn't quit charging their time to COVID. So it's not like it went away. If the pandemic went away and those funding streams went away, our indirect rate would be back up to like 33, 34, 35%, 39%, versus 20, whatever it ended up being, 22, 24%. So I don't know if that makes sense to you, but it's that indirect rate really impacts our budget with a budget the size of ours. So I kind of wish we had kept that designated in to cover the indirect rate, but we decided we'll just put it in operating. This board decided to put it in the operational reserve fund, but we can pull it out of that. I mean, that's the idea. You guys have control over that fund. It doesn't matter what you call it.
That was the 200,000.
No, it was
No.
a million.
Yeah.
Well,
Last
that's not
year.
it. Yeah, from operational reserve to special projects. That's where that one. Madam Chair, I had another question for Bailey. Two things. Do we get any ARPA funds?
I don't think that it's come through yet. We have, okay, there is a very small pot that we got for home visiting that's like, I think it was like between 40 and 50,000. But we still haven't got word back for the like 13 million.
It's,
Something. It was a big.
yeah, there's a,
5 million.
so the legislature had to authorize spending authority for the Rescue Plan Act funds before they could come out to us. So that's not quite yet finalized. So we will receive ARPA funds other than what Bailey just described. And then we actually put in a request for, I can't even remember what the number was, like $8 million or something from Ada County. We know we won't get all that money, but they got close to $94 million. And the rest of our counties, I reached out to them, but no one seemed interested. So Ada County.
Well, I thought that was all decided. I know the counties have already gotten their first half.
Yeah.
In Valley County, we're gonna get about 2.2 million. We've gotten 1.1 already. So now we're in the process of trying to figure out where we're gonna spend that money. It can only be used on county facilities, that kind of stuff. Second question is, what about the opioid settlement dollars? When are those coming in?
I'm not sure on the specific date, but we did just get word from the Attorney General's office that it will be coming, and I think it's for the first 4 years worth we're gonna get upfront, and then it will come in increments after them for over the 18-year period.
And they just settled out with 3 more companies.
Okay.
So there's gonna be 3 other separate payments coming in as well. And I guess what I'm thinking is we gotta get ready for this money for opioid. And
We're ready.
good, because I think the county's gonna have a hard time spending it. And I've talked to Russ about this. I would rather contract with the health district to help us spend our money in the county. I don't know what Ada County or Boise County is gonna do, but we don't have the bureaucracy to deliver that program you guys do. And we'd certainly be willing to throw our money at that. Just keep that in mind.
Yeah, Madam Chair, I was gonna give an update.
Was that?
Well, the director's report, but.
Oh, okay.
We did get confirmation.
We can wait. We can wait. I don't want to spoil your fun.
Yeah, so we're getting the money. We don't.
Yeah.
know when.
Yeah, that's good.
That's gonna be a lot. Conclusion.
Okay, any further discussion, questions for Bailey? Hearing none. Thank you, Bailey.
Thank you.
For all your information this morning. And at this point, I am going to call for a 15-minute break, so we will
Here.
reconvene at 20 till the hour.
Thank you, Madam Chair. Thank you.
I was forgetting that. Okay, proceeding on with our agenda, we're going to have a discussion regarding schools masking and protecting students and staff from transmitting the COVID virus by Raul Labrador. Go ahead, Raul.
Hello, can you hear me?
Yes, we can.
All right, thank you for giving me this opportunity. As I have expressed in many of our meetings, I've been very concerned about CDH always recommending what the CDC is doing without a vote of the board. And especially when it comes to our young children and the recommendations from the CDC, we see time and time again that the CDC has incorrect data, incorrect assumptions. And I'm just going to give one example that just happened within the last week. If you know, the CDC had to report fewer COVID-19 pediatric deaths after data correction. And if you read all the articles, they all say, they kind of make it sound like it was just a small correction. It was actually a correction of 24% in the number of pediatric deaths, which is a pretty significant correction that they had to make. So a lot of the assumptions that we're making about masking, about other things that are happening with our youth, I really believe that we're breeding more panic and more fear than we're actually following actual science and data. I actually could not speak any stronger or better than the lady that spoke earlier today, who was one of the people who came forward to testify as a school teacher, as a person who's learned other languages. Just the importance of children being able to see the entire face of their teachers and their peers. And I think she just did a beautiful job explaining the difficulty for these children. So I think that it would be very important for us as a board to be very careful about any types of recommendations that are coming from the CDC, and that we don't just allow the staff to issue recommendations without having an actual vote from the board. Generally, I wouldn't have a problem with recommendations because in my mind, a recommendation is a recommendation. That's all it means. But when you talk to the school districts, every one of them says that if the Central District Health Board or any of the district health boards are recommending it, then they're going to go along with it. So they're looking at it more as an order than they're looking at it as a recommendation. So our recommendations actually carry a lot of weight in what the decision-making process in the school districts. And I think we need to be very careful. At some point, I want to broaden this discussion a little bit further to other recommendations for children about COVID. But today, since on the agenda, the only issue that we have is the mask mandate, I'm going to limit it to that today. And with that, I would like to start a discussion and see if any other members agree or disagree with me.
Okay, the floor is open for discussion.
Madam Chair, I would like to second Raul's comments, and I would like to also thank Peggy for her very astute presentation. To Raul's point, on President's Day, there was an article that came out in the New York Times on a slow news day saying the CDC has withheld the majority of their data from the United States citizens. So we have made decisions as a nation based on very little data from a poor data gathering agency compared to other nations in the world. If we look at other nations like Sweden that had 1.8 million children that got to live normal lives during the pandemic, no child died. There were no children deaths in Germany. We've done things here that, following certain governmental agencies that withhold data from us, doesn't make for good science. I know there's strong feelings and beliefs, but if we go based on science, then we as a board need to make science-based decisions. We can certainly listen to what they have to say, but if you don't have transparency and you don't have all the truth, then you can't be trusted. And I think as a board, we need to be truthful, transparent, so we can be trusted as a health agency, just as any other health agency or governmental agency should be. Anything in politics, truth plus transparency equals trust. The masks have been 100% unnecessary for 2 years. If you want to look at brownstone.org, there are 150 studies compiled by Dr. Paul Alexander showing there is no evidence they ever did anything. There's not one randomized controlled trial that has ever shown they've stopped any respiratory virus. My daughter last night, Dad, all the kids at school are happy again. I'm like, why is that? This is my 14-year-old. She's like, because we can see each other's smiles. And, to Peggy's point, the CDC, just changed speech standards in terms of
Words.
words. And things like this, there's psychological damage that's done to children. There's developmental damage. There's physical damage. I mean, we've cultured plenty of masks and seen odd infections in kids that we normally don't see in the throat because of masks, the skin conditions, the breathing conditions, all sorts of physical harms. The masks are filthy. The psychological harms is what I worry about. The CDC withholding the data, I worry about that. The depression, the suicide, what we've done to a generation of kids when not everybody's at the same risk. The government said, you're all the same risk. No, children weren't. And so I think this is very important when we as a board make recommendations across the board. I think we need to stratify that according to risk. The kids need to be kids. We've seen the data now. In retrospect, I'm not blaming anyone. I'm just saying, if we go on hard-driven data, then that should always trump. And again, I know it's a controversial topic because people have feeling and belief behind it. I set belief aside when I look at data. And so for me, I agree with Raul. If there's one child still left masked in the state, it needs to stop like now because there's no benefit. And Omicron is almost burned through, thank heavens. It was, generally milder for most people, and most of the data is not even based on Omicron. So when we make decisions, policy always lags science, and so I think we need to be prudent and nimble. Now that we're in March Madness, John Wooden would say, be quick but don't hurry. So we need to make decisions that are timely based on what we know now. So those would be, and I'd like to, comment later on some of the other COVID policies. The experimental shot on the children, there's still no approved shot available in the United States. That's another thing we shouldn't be recommending now that we've seen the damage in the myocarditis in children and things going forwards. But that's, I think, a topic for another time. But I agree with Raul 1,000%, and I think we need to follow the lead. The majority of the Western world is not masking their children, and majority of the rest of the world is not masking their children. There are only 6 or 7 Western nations that still do it. So I think I'm embarrassed to say that our CDC has been very abjectly poor in telling us the truth this last 2 years. And that's based on data or lack thereof. So thank you for letting me be a little passionate. Appreciate it. Thank you.
Discussion?
Madam Chair, I'll go next, I guess.
Okay, go ahead.
I think you have to take the best available science at the time to help make your decision. What I don't want to do is get this board into a situation where we're using different studies from all over the world trying to figure out what's the best way to approach this. If I remember right, we came back a couple of years ago with the mask initiative, was the fact that all we were trying to do was slow the disease down to where we didn't overwhelm the hospitals. And we failed twice, basically. Both times they had to go to critical care, and that was an issue that we knew we weren't going to stop the spread. We knew we weren't going to cure the disease, but we needed to slow it down so the hospitals could handle that. I don't know what else we could have done to slow it down other than masks. If there's something else, maybe it's a situation where we needed to space kids out further in school. maybe we needed to do, alternate day education, because I don't know. So those are some of the things that I thought about, but, and I agree with your statement about CDC. They're always kind of late with really what we should have done and what we did. But the other side of this issue, and it happens a lot too in county government, is that we need to cover our backs so that we're not held liable for a decision we made. So we're going to use this study or this group as our reference point. And CDC was kind of the heavy hitter in the club, so to speak, at that time. So that's why we went to them and used their data. Whether or not it was right or wrong, we know now that a lot of it was wrong. But at the time, we didn't know that. But that protects our liability issues if someone does die because of something that we recommended. And that was just a recommendation to the school boards. Whether or not they instituted was their choice. I know in my little school in Cascade, the first year they masked, the second year they didn't. And there was really not much difference in the results. And so but they also spaced out those kids. The second year, they weren't sitting next to each other. They were 6 feet apart. And there were some classes, they actually had to take half the class and go to another room in order to get that space, but they adjusted that way. I think there could have been a lot more studies or looking into the ventilation systems of our public buildings. I think, there could have been some air conditioning kind of stuff that could have been done to catch this virus, so it's not circulated throughout the whole facility. But I'm happy with what we did was the rightest thing we could do at that time.
Madam Chair.
Yes, go ahead.
Thank you, all. And to your point, I think one of the things we could have focused on early was ventilation and narrow wave UVC light that a lot of schools, I know one congressman in, I think, South Carolina got it for his district. And to your point, that second year where the kids were spaced out, by then a lot of them had already had COVID. And that was another thing we ignored was natural immunity. Because once you've had the disease and you're recovered, your chance of getting it again are far less than 1%. And children actually, if we had looked at the early studies as well, weren't primary spreaders of the disease. That was a big study that came out in Germany early, and then other countries replicated that because children don't have the receptors for the virus that we've experienced at their age that's not as upregulated. So they weren't primary binders and or spreaders of the virus. But I like your idea. I mean, if this were to ever happen again, long before ever even, attempting to put a mask on a child, I would say, what are we doing about the ventilation system? And do we have UVC lights killing virus that's circulating through the room? Because that was the one thing, well-ventilated spaces were the one thing where the virus didn't spread. So that's a great point. I appreciate you bringing that up. But going forward, and again, I'm not here to, throw blame, but now where we are at this moment, knowing what we know and knowing what harms have been done, knowing what data we do have and or what has been withheld, I think going forward at this point, it's easy to strongly recommend on a very data-based point of view that let's let children be children and not have them suffer anymore for those of us who are at higher age or risk groups when they're not. So I appreciate, the conundrum that everybody's experienced. But now post-mortem on it, I think we can look back and go, okay, time to think and act differently based on where we are now.
Yes, Raul, go ahead.
Madam Chair, just 2 points. Number one, I want ELT and everybody to understand that I'm not looking backwards and saying, hey, we made mistakes and we need to stop it and we need to cast blame for those mistakes. I'm just looking forward, not that we have more data. I think we need to be more careful. So that's number one. And then number two, I'm not suggesting that we recommend children not wear masks, which would, maybe incur the liability that ELT is talking about. I'm just saying we need to stop recommending the mask and let people be individuals. There will be parents who want their children to wear masks to every single event, and we shouldn't shame those parents. We shouldn't shame those children. We shouldn't discourage them from doing that. But the parents who don't want their children to to wear masks shouldn't hear every single time, well, we're doing it because the CDH told us that they're recommending that we do it. I just don't want that recommendation out there. If the schools want to rely on the CDC data, if they want to rely on on the science that the CDC is working on, then they can use the CDC as their crutch. I just don't want them using the CDH, because the CDH is the staff that has made that recommendation. We're the policy making body. And I think before we make recommendations about masks in classrooms and other things, I think those issues need to come through the board before those recommendations are actually made. So but I'm not saying that we should recommend no one wear a mask, because I think that would be irresponsible as well. I think parents and teachers should make decisions for themselves if they want to wear a mask. Parents should make decisions about their children, but we should not be recommending them, because I don't think the science is there to back it up.
Well, and our goal all along has to get our positivity, as to El's point too, and not to stress the hospitals, but to get our positivity rate below 5%, which we're there.
Well, and at that time too, the first year, we didn't know what Corona was. Everybody was kind of like, we don't know if this is going to be a serious virus or if it's going to slowly kind of genetically breed itself out of existence, which is exactly what it did. But, to me, if you have a new virus hit your population, you don't know what it is, you want to take every step you can to protect your population. And then learn 2 years later that, we didn't need to do that. And I think that's appropriate. That's just the way life works.
Yeah, and that's been, Madam Chair, that's been a frustration for me, because we did know early on. If we looked at SARS-CoV-1, and that hit the elderly, generally not the younger, and it hit comorbid, high risk. And then we had the USS Roosevelt and the Diamond Princess, which were perfect lab models, comparative models of who was at risk in the military. Only one person had an adverse outcome, had comorbidities, whereas the Diamond Princess, you had elderly comorbid. So we knew early. And so, again, I'm not like Raul, I'm not casting any blame, but this is an example of where public policy, and I understand, people don't want to be liable, but at the same time, it's that fine balance of, okay, we know a risk category, and never in history we quarantined the well, and nothing we did really stopped it. Lockdowns, masks, et cetera. Dr. Alexander has 400 other articles on that. But at the end of the day, where we are now, to your point, where Omicron's burned out, virus is going to virus no matter what. That's what we know. Thankfully, we're in a better place. To Raul's point, if somebody feels comfortable with the mask, that's their personal physical choice. But I think at this point going forward, we as a board and anything coming from CDH should be based on where we are now with the science. And it would be, I think, prudent. And again, I understand your perspective and point of view. We didn't know everything at that point. Now we are where, the retrospective scope of life is always easier. So, but now that we are where we are, I think, prudence dictates that we act on what we know now. So thank you, El. I appreciate
Madam
it.
Chair, I have a question for Raul.
Yes, go ahead.
Raul, do you feel the same way with the nursing home protocol that we came up with?
So today I'm just speaking about children, and I have less experience with the nursing home protocol. But what I worry about is when I talk to parents constantly about this issue, they say that the school always tells them that they have a mask mandate, or at the time that they had the mask mandate, because the CDH recommended it. And I always remind them the CDH board did not recommend it, the CDH staff recommended it, and we've never taken a vote on this. So they come to me looking to me, why did I recommend this? And I said, I did not recommend this. And that's what I'm worried about, is that we're setting policy about something that is affecting every Idahoan, especially every school child within our board's jurisdiction. and we never voted on it. And I don't think we should be making these decisions. We're the policymaking body for the CDH. And I think, and maybe when the vote comes up before the board, we will vote to recommend the mask or whatever other things are. But right now, these recommendations are being taken at face value. The school districts are using them as really their crutch for making these decisions. And I don't think the recommendation right now is justified. So I would like to remove that recommendation. On the other issue, I mean, we should start thinking about a broader policy vis-a-vis COVID. Maybe we look at everything else, but I'm just starting with this. This is just a small step to make sure that we're following the science and we're doing the things that are good, that are, because pretty soon we're going to start seeing how this is affecting our children, and it has affected our children very negatively, and we need to make sure that we don't allow something like this to happen again. I don't know if that answered your question, Elt.
No, I'm just concerned about if we have a policy that we're not listening to our specialists here in this facility and they're recommending a certain practice and we say, no, we're not going to approve that. What is that going to do to us as far as a liability issue?
Actually, maybe I'm not explaining myself also, if I could, Madam Chair.
Yes, go ahead.
Yeah, that's actually exactly what I want. I want our experts to convince the board that it's something that we should have. So I'm not suggesting that we shut down the staff from giving us recommendations. I'm just suggesting that the recommendations should not be made by the staff. They should be made by the board on this particular issue. So of course, we're going to have a discussion and debate and have the staff come to us and recommend. And I may be, sometimes on the losing end of those votes. But that's all I want is the opportunity to vote on it, the opportunity to actually have an open debate, not just have a memo come out from CDH saying that we recommend mask mandates. The next thing's going to be we recommend vaccines for children. And all those things need to happen after we have an open discussion and debate. So no, I'm absolutely not suggesting that the CDH staff not have the opportunity to present to us what they think would be the proper recommendation for, vis-a-vis our children. I hope that clarifies it a little bit. I'm not saying let's shut down any kind of recommendations. I just think there should be a vote on those recommendations before they go forward.
What else would you like to weigh in?
Sure.
We're almost to the end of the school year too. So.
Right. So Raul and I've talked about this a number of times, and I think what he's asking is very fair. If, we'll have to define it like we've done with social media, for example. As we talked, and I know there's interest, and Dr. Cole just alluded to that too, for other recommendations, and we can put that on a future agenda. It didn't make it on today's agenda. So the idea is, as I am listening, is before we would make today recommendation that children and staff wear a mask in schools, that you would request that we bring that recommendation to you for you then to vote on. So we would bring whatever research studies. Now, granted, and I appreciate the confidence in our team, because I have great confidence in them too, but we don't have extensive research capabilities, right? We have always looked to Centers for Disease Control for everything from waterborne outbreaks to the current syphilis outbreak we have going on. We're not changing our practices, and you're not asking us to do that. That's not what Raul's talking about. He's very specifically talking about COVID and COVID recommendations, which I appreciate. We also rely on the Department of Health and Welfare. So we don't just say CDC adopt blanket whatever said, but the Department of Health and Welfare, who has infectious disease specialist, physician, Dr. Chris Hahn, and the rest of the Dr. Turner, epidemiologist. And then, but again, to me, that's what we'd be bringing to you. And I get anytime you put any type of recommendation out there, there'll be some people who adopt it and some people who resist it. And in the case of schools, 9 out of the 10 school districts, as you mentioned, Commissioner Hasbrook, haven't followed our recommendations anyway for this past school year. One did, and that's Boise School District. So we made the recommendation. They exercised their authority as a school board to make that determination based on our recommendation, based on Dr. Nasser, based on Dr. Souza, based on all these others. It wasn't just us, you know, because I listened to the school board meetings and I know who they're talking to. This is specific to this board and the recommendations that come out from this agency. Today it's related to math in April or May, whenever you'd like to discuss, just let me know and I'll put it on the agenda. So I think operationally we can do it. I think the request is fair, and just let me know how you'd like to proceed.
Well, I think you probably just outlined a good way to proceed in conjunction with what Raul and Dr. Cole have both said, as well as, yeah.
But I think it should be a formal written policy. Something like into some kind of a handbook or something so that we have this, because we're not all going to be on this board forever.
Right.
And so the future boards know that this is, you know, this is how we kind of operate in this health district. I'm just keep running through my mind, if we'd had this policy 2 years ago, what would have been different? Because we didn't have all the studies out yet.
You know, that's an interesting question, and this has been a large frustration I've experienced, is the lack of the ability to dialogue and bring opposing studies together or opposing voices, because, you know, to Russ's point, you know, certain voices were very strong in this way, but people who thought otherwise weren't allowed to express. So to that question, bringing a lot of people to the table, like people from OSHA saying, look, everything we're doing with masks, I have a lot of OSHA expert friends around the country, violates all OSHA standards, what we've done, et cetera, et cetera. You can't use masks this way. And even the federal government through OSHA guidelines to the side. So having experts, I think the key in any good politics is listening to everybody and never bring an umbrella to a brainstorm. You just sit and listen, because everybody has a point of view. And then you distill that to something reasonable and logical.
This would certainly allow that debate.
Yes.
Jane, it's your turn.
Jane?
She's smiling.
I'm listening.
So I like the way, Madam Chair, may I speak?
Yes, go ahead, Raul.
I like the way actually that Russ framed it, and if we could formulate a motion in the way that Russ framed it, and put it down, and like Elt said, if we could do it in a way that can be in a written policy. So if you could help me maybe formulate the motion, I would like to make that motion.
Well, I have a question along that line, Raul. I was getting the idea that we wanted to have a number of people come back with a discussion at our next meeting. And maybe would that be a more appropriate time after we get their input to actually have the motion and to put it on next month's agenda?
I would be open to that.
The board open to that?
Madam Chair, maybe what we could think about is in the meantime, Russ and Raul could write up a policy and send it to us before the meeting. We can look at it and say, yeah, I like this policy or I don't. Just to give us some paperwork to write on.
I welcome that idea.
Okay, thank you. I think we want to give this deliberate thought and not act impulsively on anything. So we'll put that on April agenda, okay?
Done.
Thank you. Thank you, Raul.
No, thank you.
Okay, now Randy, it's your turn. He's going to tell us about his CDH continuity of operations plan. So go ahead, Randy.
Thank you, Madam Chair.
You can go up to the.
We want to see what you look like on TV, mister.
I'd rather not have the camera to
Oh, sorry.
not getting off that easy.
Nope.
So, as you're maybe aware, but Central District Health has maintained a continuity of operations plan for a number of years now, which has the primary purpose of giving us an opportunity to provide critical services, what is important for us as a entity, what causes us to be, and then identifies what those critical services are, identifies staffing to fill those services, and then also identifies some orders of succession for staff should a catastrophic disaster or emergency impact the building itself or us as an agency. So in the continuity of operations plan, you'll see a couple of different listings in there. The members of the board also have a summary of changes to the plan, which includes some updates to some of the job titles, job descriptions that we utilized, includes some specific orders and succession changes with some of the offices. As you're aware, the one constant in our business is personnel changeover. So, certainly in this room, the example is Jamie rejoining us as our Division Administrator for Community Environmental Health, Gina taking over in Family and Clinical Services. But that creates a change also in the orders of succession to succeed Russ's position, should that become necessary also. So the plan itself, by and large, is consistent with what we've utilized in the past. It helps us as an organization implement some and have available to us some tools as it relates to our ability to support the community and fulfill our role in supporting the counties and also the county's emergency management efforts. So I'm happy to answer any questions, thoughts about information that's contained in this continuity of operations plan. I will say too that I know early as we were initially standing up our response to the COVID situation, I know that leadership here, we were going back into our continuity of operations plan and making sure that our critical services were going to be served and that we had the right staff in place, either in the building or available to via telecommuting and or some other just non-interactive issue with the clientele so that our staff could continue to do their jobs. Certainly, we saw WIC services are one example of one of the critical services that we provide, but our WIC staff were able to continue to do the work that they do and support the community members with that vital program through us and telecommuting and being able to telecommute with their clientele as well.
Randy, on page 8 here, would you just tell me exactly down here at the bottom where it says restoring normal operations of the hot wash mean? Exactly what does a hot wash mean?
Hot wash?
Uh-huh.
Hot wash is a little bit of jargon in the emergency management world, but
Okay.
it's really an after action review.
Okay.
So that would be the easiest way to describe that. We see it not only in the emergency management world, but it's a term. I have a extensive military background as well, but it's a term that I'm used to from my days of serving after a exercise or some other actual event. But we would do a quick hot wash after the event just to review what happened and what did we learn. Did our standard operating procedures work for us during that event?
Okay, we just use different term in hospital.
Sure. Yeah.
Why does?
Madam Chair,
Yes, go ahead.
Randy, what I like most about this is you've actually got people listed as successors, actual names.
We,
I might suggest that you put a contact number or an email address to those folks. Just so that if I'm from Valley County and I don't know this guy's number, I could call him. Or someone can. I think that's important to have the actual people. I know we do this with the state, we do this with the Forest Service, emergency plans and that kind of stuff, but,
Yeah, I think you bring up a good point to that, Commissioner Hasbrook. And certainly, contact numbers we've had in the past in some of our planning documents like that. One thing that we noticed over time too was that not only do faces change, but sometimes their contact information changes. We certainly have those lists available, but yes, those are things that are easily added in.
well, and it's like something you almost have to update on an annual basis.
Well, and this is document certainly that we do.
It's nicely comprehensive.
Mhm. This is evolving documents to keep up with the times reevaluate it how often?
Every year.
Every year, just in.
And then through our public health emergency preparedness program, this is one of the documents that we provide back to health and welfare on an annual basis, just so that they're aware too that we're meeting the nature and scope of the public health emergency preparedness grant that we participate in with through the CDC, and then also just in collaborating with both health and welfare and with the other stakeholders.
So, Madam Chair, are you asking for us to approve this? Just an action item? Or just a review, okay?
Just a review. It's down, it's listed on the agenda, it's just a review, is that?
Yes, ma'am.
Nicely done.
And it will get Russ a signature based off of this meeting, and we'll go forward.
It's great. Thank you.
Very good.
So, Madam Chair,
Director.
speaking of turnover, Randy has been with us for a lot of years, not quite as long as I've been here, which is a really long time. But he will be leaving us on April 15th. He's going to work for Ada County Emergency Management, who we have worked with extensively. We have always worked with them, but more extensively for the last 2 years. So I want to take this moment to thank Randy for all his time and dedication and hard work and commitment to our CDH community. And it's been a real pleasure, and going to miss you.
Yes.
And the fortunate part is that I'm just going down the street a little bit. It's been my pleasure to be part of this team and to work very closely, not just with Ada County Emergency Management, but Commissioner Hasbrook, I know that you're an active participant with the Valley County LAPC Local Emergency Planning Committee that we do. And we do the same work with all 4 of the counties.
Have you got somebody in mind to take your place, or is that going to be an open position for a while?
We started recruiting it yesterday, I believe, and we have a couple of other new staff on our emergency preparedness team. And we have some real strong young hitters that are coming in to fill in the gap behind the old guys. So I'm very confident in the future of the program. And again, I'll be right down the street too to help provide any desired support as necessary.
Well, and I want to thank you from Valley County for all your help on our issues. Just so you guys know, a county has to provide an annual emergency operation plans and an all hazard mitigation plan, and they have to be updated usually within every 5 years, I believe, or 10 years. And if you don't do that, if you don't have updated plans, you don't qualify for any FEMA money. And FEMA money is for bad situations, hurricanes, floods. In our case, we use it for a lot of washed out roads. And in Valley County's case, we had a road up between Yellow Pine and Stibnite that took out a couple of years ago. The snow slide filled up the river, washed the road away. And it meant about 700,000 FEMA funding. We got reimbursed from FEMA to fix that road. And if we hadn't had those plans, which Randy helped develop and design and update, we would have never qualified. So it's kind of important.
Well, our program takes great pleasure and great pride in working with all 4 of the counties that we're providing services to. I'll miss the direct work I get to do with Carol Kelly and down in Elmore County.
Yes, Carol and I are buddies.
Are you?
Yes.
I haven't had a chance to share this news with her yet, so
Okay,
I'll sneak that phone call in.
all right. We'll tell her I got to find out before she did. But thank you for your help.
Thank you.
Yeah, in Elmore County, we have this challenge of what the highest percentage of motor vehicle accidents between like the stage stop and west of Hammond, any place in the state. So,
Really?
yes,
Yeah.
yes, we do.
All right.
But thank you, Randy,
Thank you.
and good
Thank
luck,
Thank you.
joy and success.
Thank you very much. I appreciate it.
Thanks, Randy.
And thanks for leaving us nice and organized.
Yes, nicely organized.
Pretty dope planner.
I love it.
All right. Okay, Russ, it looks like we're looking at these potential resolutions,
Yes.
IAV. Go ahead.
Okay, so again, just a little bit of background for newer board members is, for Dr. Cole, you probably served on a lot of different associations and boards. So the resolution process is the statement of like policy, things that we would like to work on as a body, not Central District Health Board, but as the Idaho Association of Local Boards of Health. So we meet in June, discuss resolutions. If they are approved, then that sets the direction for the next legislative session, or sometimes they could be county ordinances or city ordinances. It doesn't always have to be statewide, but often they are. So COVID disrupted a lot of things. One of them was IAB and resolutions. I don't even think we've had any resolutions for the last 2 years. I can't think of any. We discussed ones that were going to expire after 3 years per IAB policy. But this year, Public Health District 3 they've submitted 5. And in addition to these, if there's any topics that you think should come before IAB, you can let me know, and I'll work with the team here to draft the policy. So I'm going to go through these. If this is District 3, so we don't wordsmith them, but if you have general questions like for kratom that should be outlawed versus age 21, I can pass that on to Nikki Zog to share with her board. But unless we created our own, they are the authors. So now, with that said, in June, there'll be plenty of time to wordsmith these. That happens then. So
Do we have to give thumbs up or this month or next month?
So
The ones that we support.
So this board doesn't get to vote on them until June.
Right.
So you don't, if you, like I said, I'd say this is mainly for awareness. I'm sharing it with you today. If between now and really June, if you had some major policy guidance that you'd want to offer as a board, I could pass that on to Nikki, but you won't get to vote on these until June, and you vote on them as individuals.
Okay.
So that's the policy. Here's the resolutions. I think they're good. Commissioner Hasbrook and I talked, in fact, I was going to draft the one on the food license fees, and
Here it is. Last one.
Nikki said, well, we're already working on it. And I said, well, please do. So in fact, it's just an update of what we've already had in place. As you mentioned, Commissioner Hasbrook, we've been talking about it for a very long time. And in this legislative session, just the timing on it because of election year.
We put the brakes on it.
Brakes on it. So anyway, here's the resolutions for your awareness. And again, if you have anything you'd like to share with me to pass on to Nikki, you could do that today, or you could do that via email directly to me, and I'd be glad to pass it on to their board. So with that, if you do have anything, let's talk about it, but also if there's other public health topics of significance that you think we should be looking to, either county level, city level, or state level policy, that's what these are directed. They're not just, although we've had some that are just feel good type resolutions, but they don't really,
Most of them are.
yeah. But if it's directing, you know, really me and some of the board members, like you'll probably be involved in food fee legislation, talking to legislators, going and testifying. If there's anything that you can think of now or between now and April, shoot me an email, good to copy the whole board, you know, just so you're aware, I want to work on this topic and I will put forth a draft resolution to share at the April meeting. Just let me know. I haven't received any other than from District 3.
Madam Chair,
Yes, go ahead.
Russ, has there been any discussion from other districts on the fentanyl issue that's going on right now?
Lots of discussion, not a resolution.
I know, I don't know where to attack it, honestly. I don't know how. I know we've worked a great deal up there on making sure all of our EMS law enforcement have Narcan and all that stuff is available for those OD folks, but we're getting a lot more issues with it in the state.
Yes,
We had record overdose deaths in America this past year.
that's right.
It's tragic.
But I don't know what kind of resolution to, because it's illegal. I don't know, maybe more law enforcement on the border or something, but I don't know how to attack that.
I don't either, because the problem, I mean, treatment and all is wonderful. But how do we curb the growing demand in our younger population? Because it will always create its own supply.
Yeah, I just wonder if we could do something like they did with the COVID test where you got your own Narcan at home or at schools or something like that, that it's available. But most of these people aren't dying at school. They're at home when all this happens. So I don't know, more Narcan dispensaries or something. I don't know how to attack it. It's just absolutely bizarre.
It is.
Madam Chair.
Yes, go ahead.
So as you guys probably already know, fentanyl makes its way into lots of different illegal drugs. It's not, hey, I'm going to take fentanyl. So
Right.
it's the inadvertent, unintentional, although often are using some type of illegal substance anyway. So we have a pretty extensive program. I don't know if you saw it in the news that we were Mount Home teaching teachers and law enforcement and social workers. We do that district-wide. It very much involves the Narcan component where people can get access to it. So, you know, we are addressing it. And of course, if we get when we get the opioid settlement money, we'll be expanding that effort. So that's more very much educational, systems building the capacity in the community to be able to respond on the prevention side. We do work around that too, but to your point, I don't know, you know, the governor's taken a real aggressive stance as well. I'm not aware, Jamie, you might be, that's your team, if there's any types of policy issues that we could address on a substance that's already illegal. But we can think about it.
Yeah, I mean, those all stuff.
Okay, yeah, but our team's really involved and passionate about the subject for the reasons Dr. Cole mentioned. It's first started talking about the opioid settlement. It's hard to believe we're still talking about it. And we need to, because it's only getting worse. It's really unfortunate.
Well, this resolution for an excise tax on the nicotine, vaping, like, you know, these all sound like great ideas, but we know what we've run up against with the lobby in the legislature on tobacco issues. So that might be a waste of time.
Well, I think the tax on nicotine vaping is the same as cigarette tax, isn't it? Didn't the legislature do that 2 years ago?
Madam Chair,
Go ahead.
I am not certain. I know it's been debated,
Yeah, maybe just.
but I don't recall that they ever placed a tax proportionate to tobacco
To
on
proportionate, yeah.
vaping. But I can look into that.
I know a pack of cigarettes now, I think is $7.35.
Yeah.
But the age is 21 now too. We finally got that done after how many years?
So Madam Chair, so yeah, that's been federal law.
Yeah.
And I think any provider, of tobacco products in the state of Idaho, I think most were, or all of them were already following the federal law. But the enforcement usually happens at the local level, and the legislature, just this session decided to create parity between our law and the federal law that already applied to Idaho. So that was good. Couple years.
So we used to have a resolution that people businesses that sold cigarettes had to have them under the counter so that little kids couldn't see them. But I don't think that ever went anywhere now because they're all just laid right out there in front behind the gas register. That one went away.
And my long-term concern is just the other substances, just like in cigarettes, that do more damage, like with this vaping product, the acrylamides and things that are, who knows what long-term lung damage these poor kids are gonna have. And they make it, colorful and flavorful and appealing, and unfortunately, long-term side effects may be catastrophic.
And what's interesting to me, there's a great one on YouTube, if you get a chance, on vaping now, where tobacco companies pretty much own all the vaping companies.
Oh, cool. They bought them.
So they're getting on both sides of it now. It's like, wow.
Well, these are great. Thank you, Russ.
Yeah, sure.
I may have an idea or two, but I mean, the suicide one hits close to just a lot of life experience that I've gone through with a lot of friends and family and people. So I have some ideas just in terms of a line or two of recommendation. Just, I think, new areas to be looked at that are additionally helpful. So I'll email you something on that one.
Great.
So thank you for including that one. That's a huge part of societally what we're experiencing as well right now. So thank you for including that.
I actually have a question more directed for Dr. Cole. Do you know where we can get more information about Kratom? I don't know a lot about it. So I'd like to know more about it and kind of be able to make an informed decision on that whole situation.
Yeah, I'll send you I've got a couple synopsis papers on it. I'd be happy to send those up to you, Ryan, and anybody on the board if you want a couple of medical papers on it and just what it does and how, yeah. I'll be on a plane this afternoon, but I'll be back Sunday night, so I'll try to get a couple of those medical papers to you because it's an interesting, I mean, it's used in certain parts of the world heavily, and in other parts it's obviously not. So, it's a stimulant. It's different compared to a lot of other things that are out there. So I'll be happy to give you some medical updates and maybe just a synopsis and then the attached papers.
Great. Thank you. Okay, moving on. Director's report to Russ.
Okay, so I have a couple of items, things I listed on there, and a few others that are, this is all updates. So already talked about April 15th, you'll get a budget to approve. You'll get 3 options that we talked about. We'll put those together. And then on May 20th, we have the budget hearing. So that's the budget committee, the chairs or their designee from each of the counties will get together. This year, it's on May 20th, 10 o'clock. Boise County is the host. We rotate that around so that you all have an opportunity to meet in the other counties besides here at our office. Donna has worked with Horseshoe Bend City Hall is where we're going to have it. We've had it in Idaho City the last 2 times they've hosted it. So we thought we'd change the scenery and it may be a little bit more convenient for a lot of you to go to Horseshoe Bend City Hall. And Commissioner Twilliger from Boise County will be hosting that. Now, I will put one caveat in. When we were planning to do this, Commissioner Sturm was the chair when we first started talking about it and Commissioner Sturm, you can probably provide a little more intel on that, but basically now Commissioner Twilliger is the chair and he over in the Idaho City region. So timing for, at least for him, he'll have to drive up over the top and down Harris Creek, which I think he would do. I gave him the option to let me know if he wants to change course. So as of today, the plan is to do it at Horseshoe Bend City Hall,
10 o'clock.
10 a.m. The budget,
I'll be out of town.
okay,
I'm in London for a World Council on Health meeting.
okay,
So
No.
can I zoom in or maybe?
You could.
11?
yes.
Be middle of the night for me, but I can zoom
Yeah.
in from over there.
Yeah, I say it with confidence. I wonder what the technology is.
Yeah, that's why I was asking this, even if I'm just on a laptop, you know.
Yeah.
Zoom to.
So I can speak to that, actually. So the city of Horseshoe Bend has used some of their CARES Act funding to facilitate Zoom meetings in their city hall.
Okay.
So that is, they have all of the equipment, and I don't know how many of you know Mayor Goff, but he is actually the IT director for several school districts. And so that just kind of worked out in Horseshoe Bend's favor. And they have all the capabilities for Zoom meetings at the Horseshoe Bend City Hall now. So that portion will not be a problem. Just have to set it up with the city and the city clerk to give everyone access code to be able to get in and be involved from that aspect. And then to kind of touch on the chair position, because I'm running for election this year, we went ahead and rotated the chair over to Commissioner Twilliger for the remainder of the year. And then we'll realign that back in January. We just, don't know which way that's going to go, but depending on how the election goes, then we'll have a vote and realign that in January.
Thank you.
Thank you, Ryan.
Thanks.
So that meeting is the budget committee meets. So we're not, you would be, because you're the chair, part of that, but we will also convene the Board of Health meeting immediately upon adjournment of the budget meeting. So usually the budget meetings last 5 minutes, yeah, or 2 minutes. Sometimes they last a little longer. But then we'll have our board meeting. Okay. Three other real quick items is four other. House Bill 316 implementation has gone, as far as I'm concerned, extremely well. We have agreements with all the state agencies that we worked with previously. One thing I want to note is there were two bills that were, I would call them cleanup bills, House Bill 515 and House Bill 516. 516 was just saying you don't have to comply, made certain the state merit system, and you need to develop your own personnel policies, which we have already done. You've approved working at CDH. That's our basically our personnel manual that guides those decisions. Like to give credit to, even though she's not on, Representative Blanksma. She helped navigate the waters for 515, which essentially did the same thing, but there was an amendment made to that that was really important. State risk management under the Department of Administration had some guidance from one of the deputy AGs that you can no longer cover public health districts because they're no longer state agencies. Of course, we reminded them that we have never been state agencies, and we've had an agreement with them since at least 1977 that they provided coverage for us. So talked to Representative Blanksma. She worked with Senator Harris, and we got that language placed into an amendment to House Bill 515. It'll save us about $100,000 a year compared to trying to go out and buy our own. So that was a really good deal. That policy ends on June 30th, and instead of it ending and us having a different plan, we looked at ICRAMP and others, and there's going to be three times what we pay today under the state plan. So we'll keep on rolling after July 1, and as we have for the last close to 50 years.
That's
So,
really good news. That was a big concern I had.
yeah. And Representative Blanksma was a floor sponsor on the House side, so that was really good of her to do that. And they had to do it pretty quickly because it's trying to get quotes, which took a long time because iCrimp was where everybody directed us to, and they had to understand our businesses, et cetera. And then it started to come out. We're like, whoa, we're running out of time with the legislative session. So she made it, she really was very instrumental in help making that happen. COVID-19, you're all aware, I mean, it's really, really faded in the United States and in Idaho. I get hospital data updated weekly. They're still, and maybe forever will be patients in the hospital with COVID. Very, very few, like a lot of the days are 0 in ICU. And this is talking like really the Treasure Valley is where most of the patients end up. So good news, any of the BA.2 that's being discussed and I think informally called Deltacron, but what is expected is that because of the natural immunity that Dr. Cole talked about between Delta and Omicron and the vaccines, that we're not expecting any type of big surge or significantly more severe than what Omicron was, which was quite a bit more mild than other previous variants. So today it's all good news. We know it's one of those subject to change because it's a virus, but hopefully we're out of the woods and we'll stay away from the trees forever. Millennium Fund. Happy to report, and thanks to all of you who reached out to your legislators. As I notified you, the governor removed us from the budget for tobacco and vape cessation. We were successfully able to not only get that amount, which is about $780,000 to be distributed among the 7 health districts. They gave us another $500,000 to work on tobacco and vape prevention, not cessation, and we working in like elementary schools and junior highs, which I think we've kind of missed the boat a little bit on that, especially as we move to the peanut butter and jelly and cotton candy flavored vapes. We're still thinking about the pig lung and the black, and that there's other issues going on now. So that was pretty darn cool to go from zeroed out to an extra $500,000.
And that formula is weighted.
So the formula is distributed, based on a number of factors. The $500,000 will be divided 7 ways, which is fine. It's building the curriculums, and I mean, fine. It's
okay.
I'd rather forget
So the
30% of that.
$500,000 is not weighted for
No,
population.
so-
Okay, so
no.
the
Well, and it was
750 is.
really interesting to me. Those senators had no idea about it. They really didn't know what it was, and they just thought, well, we'll just take it out, give it to somebody else. And when we notified them, let them know, hey, this is kind of important to the health districts. We've got everything set up. We're already doing this. Why would you take this away? And they all turned right around and gave it back to us.
Yeah, and what was I presented on behalf to the Millennium Fund Committee on behalf of the health districts, and it was a pretty good experience. You never know what you're going to run into, but they were like totally on board and perplexed at how the money would be, and tiny bit of commentary, the money was going to be moved to Medicaid, and it's like, really? So anyway, that was cool. I sent you, this is two things. Dang it, this is it, just 2. 5G. So I sent you an email. There was a gentleman from Eagle who requested he reached out to me through Raul to do a study, and then based on the study findings, if they came to be that his concerns were around heart issues, that then this board would do specifically a cease and desist order to all the providers of that technology. So my recommendation is that, and I let him know, I share it with the board, which I did. And my recommendation is that we refer this to another organization. And I'm not sure who could do the research on that. We certainly don't have the capacity here. It's not something we've ever done. I know it's being looked at around the world. I'm not dismissing it by any stretch, but I think we'd find bottom line is we don't have the capacity or the resources to do the proper study that would hold up, because this will end up in courts, I think, as you alluded to in our communication. So if it's okay with the board, unless you have a different opinion, I'd like to get back to this person today and just let them know that we're, obviously sympathetic to his situation, but that we'd recommend that he start, I think Department of Health and Welfare would be a great place to start. And maybe one of the universities to see if they'd be willing to engage in the research aspects.
Yeah, I agree with you because it is, kind of a controversial in the zeitgeist right now. And my background was in aeronautical and astronautical engineering at the Air Force Academy. So understanding some of the physics aspects to that was my very idea. Let's bounce it to the university and say, well, you guys going to that point of bringing data from all sides, let's go to the experts on that and answer him respectfully and say, look, we appreciate your concerns. And the distance you are from any wave source is logarithmically inversely proportional to your distance from it. So if I'm standing in front of a 5G tower, I'll get fried. So will my honeybees. But if I'm standing this far away, the amount of signal and the amount of energy in that wave is logarithmically less. So, things like this, going back to my engineering physics background, I think, great, let's bounce it to the engineers and physicists.
Okay. So if everyone is okay with that, Commissioner Sturm, you're okay with that, then I'll pass that information back to him today.
Yes.
The last item, I promise. So the IAB agenda, the draft I sent to you all, this is the first draft. I'll resend it again. So you don't have to decide on this, but these are basically all the topics, or you can pick up if you would like, copies. I'll resend it electronically. But if you have input on it, let me know. I was going to share it out with the other directors because they may have some ideas. We write the agenda, but we don't decide the agenda. That's input from everyone. And our very own chair, Nettleton, will be the chair of the.
I thought that was a trustee's job, or the executive council.
Delegated.
No.
So that was it. But if you have any input on any topics you want to put.
You're gonna have to resend it to me out. They're not here. I don't think I have this.
I don't think I did either.
Okay. Well.
Nope.
Here, you can have my.
I got lots of coffee. I came prepared for once. Somewhat.
Can I come down here for that IUB?
Yep.
That'd be all right. Are you gonna come in or are you gonna stay home?
Maybe I'll try to come in.
We would meet here.
That
You
way
guys
it's all,
welcome to come.
I don't have to worry about the IT side.
Yeah.
Right, yeah.
That's all I have for the director's report. Thank you.
Okay, all right. Okay, well, next item is we are going to, Elton, we need your coaching on this a little bit. So you deal with Elton.
What are you doing here? Oh,
Executive session, so.
Just ask for a motion to go into executive.
Yes, okay, we are going into executive session under Idaho Code 7-2061B, and we take roll call by county next, correct?
I'll make the motion that we go into executive session for Idaho Code 74-2061B.
Okay, thank you. All right, starting.
I'll second.
Okay, thank you, Brian. We'll take roll call by county, starting with Ada County.
Jane Young, aye.
Okay, Dr. Cole.
Dr. Cole, aye.
Raoul, are you still on?
He's not.
He's not.
He's not.
Okay, Boise County, Ryan.
Commissioner Sturm, aye.
Okay, thank you. Megan's not on. Valley County,
Commissioner Hasbrook.
Mr. Hasbrook, aye.
Okay, we do have a quorum there, so, okay, you want Donna to stay? Okay, all right, okay. All right, you want to of executive session under Idaho statute 74-206B. And we are we will be entertaining a motion regarding previous action regarding the salary. Do I hear a motion to that effect?
I move that we institute next week the raises or the benefits that he had, or that Russ had already okayed by the board in 2019 and 2020. And then
His evaluation.
His
evaluation will be moving to October as opposed to April. Thank you.
I'll second that motion.
Okay, thank you. Motion has been made and seconded. No further discussion. I will call for a vote by county, starting with Ada County. Dr. Young.
Jane Young, aye.
Raul is off. Dr. Cole.
Dr. Cole, aye.
Boise County, Commissioner Sturm.
Commissioner Sturm, aye.
Okay, thank you. Megan is off. Valley County, Commissioner Hasbrook.
Commissioner Hesbrook, aye.
Okay, the motion has passed as presented, and that brings us to the end of our agenda for today. I will announce our next meeting will be April 15th, starting at 8:30 a.m. And I'll call for a motion for adjournment.
Motion to adjourn.
Second.
Second.
Thank you. Motion's been made and seconded for adjourn. Call for a vote by county, starting with Ada County. Dr. Young.
Jane Young, aye.
Dr. Cole.
Dr. Cole, aye.
Commissioner Sturm.
Commissioner Sturm, aye.
Okay, thank you. Valley County, Commissioner Hasbrook.
Commissioner Hesbrook, aye.
Okay, thank you for your participation, everybody, and have a wonderful weekend
Thank you.
and a good trip.
Thank you.
Everyone have a good weekend.
Thank you, Ryan.